Members, I think we'll go ahead and get started. Good evening. Today is January 27th, 2021, and it is 5:34 p.m. As a quorum of the board is in attendance, I would like to call to order this meeting of the Central Health Board of Managers. Members, we have a very sad and tragic loss within our medical community. And it's with a heavy heart that I do want to acknowledge the death last night of Dr. K. Lindsay Dodson, who is a pediatrician here in Austin and also an assistant professor at Dell Medical School. I know our hearts go out to all of her friends, family, associates, and colleagues. Now, I would like to start off this evening by recognizing our two newest members. We have two new members of our Board of Managers this evening. Mr. Amit Motwani is joining us as the joint appointee of the City of Austin and Travis County. He is the Chief Operating Officer of El Buen Samaritano and serves on several city and nonprofit boards. Additionally, Dr. Cynthia Brinson is an appointee who is joining us new on the Board of Managers and of the City of Austin appointee. Dr. Brinson is a physician practicing with Red River Family Practice and is a medical director of Central Texas Clinical Research. We wholeheartedly welcome Mr. Motwani and Dr. Brinson and look forward to working with them to advance the health of Travis County's indigent population. Welcome to the board. Thank you so much for your public service and for agreeing to serve on this board. Our first item of business is public communication. Members of the public who wish to make comments during the public communication portion of the meeting must have registered with Central Health via the online form or by telephone no later than 4 p.m. today. Yvonne, did anyone register to make comments for this portion of the meeting?
Yes, Madam Chair, we have one member of the public who is here to speak.
All right, thank you, Yvonne. So Yvonne Davila of the Central Health Communications Department will briefly cover the guidelines for the public communication portion of the meeting and will then introduce all of our commenters by name and invite them to speak in turn. Once you are recognized, unmute your phone or computer, state your name, and provide any comment. There is a 3-minute limit for comments per board rule. Yvonne?
Thank you, Madam Chair. To be recognized to speak, you must request a speaking slot using our public communication registration form or by leaving a voicemail by 4 p.m. the day of the meeting. Individuals are asked their preferred language as they register to speak, and both the online form and voicemail greeting are in English and in Spanish. All speakers will be recognized by name and in the order their speaking request was received. If you're speaking at if you're joining us by phone, we ask that you keep your device muted until you are called on to speak. Please introduce yourself by name before beginning your comments. Also, if your comments will focus on a specific item on the agenda, please indicate the full item number. Each speaker will be limited to 3 minutes. Staff will be timing each speaker and will announce when a speaker has reached their limit. To ensure the efficiency of the meeting, once we have let speakers know they've reached their limit, we will allow 30 more seconds to wrap up their comments before they are muted. Once again, speakers will be muted at 3.5 minutes to ensure the efficiency of the meeting. Depending on the number of speakers and the total time being spent in the public communication portion of the meeting, the board chair may, in her discretion, impose additional time limits or comments. Due to the restrictions of the Open Meetings Act, the board may be restricted in discussing any items that are not listed on the agenda for this meeting. The board may choose to set aside any new issues for discussion at a future meeting. Madam Chair, at this time, I would like to call on Dr. Moody with the Community Coalition for Health to speak. Dr. Moody, will you please unmute your line?
Hello, Madam Chair. I'm Dr. Charles A. Moody with the Community Coalition for Health. I wanted to come on and let the entire committee know or commend Central Health, namely, Isela, Yvonne, and Ted. We've been working with them for several months, trying to get number one, information out to the community, small businesses, but now we've really transitioned to work directly to get accurate information out about vaccines, locations, and availability. And I want to commend them because we're getting real-time information, and that because we are the organization that we're able to pivot quickly and try to get the information to communities at large. We're working with faith communities. We're working with other nonprofits, trying to make sure that accurate, quick information about where people can access that type of those vaccines, and it's working. It's slow, and we need more of it. But I want to commend them because they are working diligently with us. More, it's not even a weekly basis. I mean, it's daily updates, and now we have pastors talking about the vaccine from the Protestant church to the Catholic church to their congregations, and this is all due to these efforts that the concerted efforts of Central Health and Ted and Yvonne and Isela and Edwin. They're doing a heck of a job, and I wanted to commend them. Usually, I can throw rocks very easily, but I have to give them kudos because they're doing a great job, and we're really partnering to try to bring these circumstances or change these circumstances to make them better. I just wanted to come on and say that and thank them. Thank you guys for all that you guys are doing, and even directing funds, energy, and personnel toward those efforts. That's really all I have to say. And I thank you guys, and I appreciate you guys.
Thank you, Dr. Moody. Thank you for your service to our community and for the ongoing collaboration. We deeply appreciate it. Yvonne?
Thank you, Dr. Moody. Madam Chair, Dr. Moody was the last speaker signed up to speak today.
Thank you, Yvonne. Since there are no more speakers, we will proceed to the consent agenda. Item C1, approve the minutes of the Central Health Board of Managers November 18th and December 16th, 2020 meetings, and the minutes of the February 7th, 2020 Board of Managers retreat. What is that item, David?
Sorry, ma'am, that one just never got approved. We've been going back through the archives and looking for ones that never got approved.
Okay.
Sorry.
So we're, as my father would say, playing catch up. Okay. Do we have a motion? Manager Valadez.
I don't believe you read C2, did you? The investments.
Oh, you're right. Thank you very much. C2, receive and ratify Central Health investments for December 2020. Do we have a motion? Manager Bell.
I move that the board approve consent agenda items C1 and C2.
Do we have a second? Manager Valadez. We have a motion by Manager Bell and a second by Manager Valadez. All in favor say aye. 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 Opposed, same sign. Any abstaining? Thank you, managers. We move now, that has passed, to the regular agenda.
Chair?
Yes.
I'm not sure if Amit was going to abstain because he raised his hand at the end. I just wanted to make sure that if you saw him or not.
Amit, were you abstaining?
That's correct. I was abstaining.
Oh, okay. Thank you. Thank you, Manager Musaitif. It's hard to watch all of the squares. I appreciate that. So we had one abstaining. Is that correct? From the minutes. Okay. Thank you. I stand corrected. So we will show that as one abstaining, not from the minutes, from the consent agenda. The motion and the second was on the entire consent agenda, C1 and C2. So we had one abstention. Okay. Thank you. All right, we will now move to the regular agenda. Item number 1, discuss the process for submission of nominations for treasurer. Members, as we discussed just in the meeting preceding this in the executive committee meeting, per our bylaws, whenever an officer position becomes vacant, we should have an election as soon as possible. As our treasurer position is now vacant, what I would request is that anyone who wants to nominate themselves or someone else do so by sending that to myself and to Mike Giesland and Perla Cavazos, so that we get those in the interim between this meeting and the February meeting. And then we can act accordingly in our next meeting. Okay, any questions, members? Again, scanning the squares here. Okay, then we will move to item number 2. Receive, discuss, and take appropriate action on a presentation of the Central Health Fiscal Year 2020 financial audit. Lisa Owens will be presenting along with Jimmy Romel from our outside auditors, Maxwell, Locke, and Ritter.
Good evening, Lisa Owens, Deputy CFO. I'm glad to be back again to introduce Maxwell, Locke, and Ritter, our independent audit firm, who will be presenting our fiscal year 2020 audit. As we presented last week, the financial statements are the responsibility of management, and the auditors presented an unmodified or clean opinion with no findings. So I would again like to take the opportunity to acknowledge our finance team, the whole team, Hattie, Martin, Elizabeth, Cecilia, Teresa, Tracy, and Joanne. They work very hard all year, and I just think their commitment to our financial excellence and stewardship of taxpayer funds is commendable. So I'd also like to remind you that Community Care and the Community Care Collaborative, who have the same fiscal year end, are presented as component units in the audit, and both of those audits were accepted by their Board of Managers yesterday, also with unmodified or clean opinions. So with that, I will turn it over to Jimmy and share the presentation. Jimmy Romel, the audit partner on our engagement with Maxwell, Locke, and Ritter.
So good evening, everybody. As Lisa mentioned, tonight we'll be covering your audit report for the fiscal year ended September 30th, 2020. We did go through this presentation with the Budget and Finance Committee last week, so we'll kind of just touch at a little bit higher level than we did last week, but obviously if you have questions as we're going through, please let me know. So as we mentioned last week with the Budget and Finance Committee, the overall content of the report is pretty consistent with what's been provided in prior years. We do our audit under government auditing standards, so we issue an opinion on the financial statements themselves, and we also include a report under government auditing standards in our report as well. And then as Lisa mentioned, there's the component units, the Community Care, Sendero, and the Collaborative. You want to go to the next slide, please? So as Lisa mentioned, we are issuing an unmodified or clean opinion on the financial statements for your year ended September 30th, 2020. And then also under government auditing standards, we noted no instances of material weaknesses in internal control over financial reporting, and also noted no reportable instances of non-compliance under government auditing standards. Next slide, please. So this slide will give a summary overview of your statement of net position, looking at 2020 and 2019 results. So kind of going all the way towards the bottom, you'll see the overall ending net position of Central Health was about $397.9 million at the end of fiscal year 20. Next slide, please. So this slide right here will show the revenues and expenses for the year. So looking in total, your revenues exceeded your expenses by about $80.8 million in fiscal year 20. And just a point of clarity, I know when we spoke with the Budget and Finance Committee last week, I mentioned a termination of an agreement with the CCC related to the member payments that Central Health used to make to the CCC. I just want to clarify that there wasn't a termination. It just, during fiscal year 20, there was no member payment that was budgeted, and hence that's why there was no expenditure recorded related to that member payment in fiscal year 20. So next slide, please. And so just some overall financial highlights. We do look at the Central Health's compliance with having proper collateral for their cash balances, and Central Health was properly collateralized during fiscal year 20. We also reviewed compliance with the Public Funds Investment Act, and we noted no instances of non-compliance related to that as well. And then also Central Health had outstanding debt of about $7.3 million, which was actually a refunding that was done during fiscal year 20 that actually resulted in a net savings of about $600,000 to Central Health. Next slide, please. And then in addition to our audit report, we do present a governance letter, which is required communication to the governing body at the end of each audit. Just kind of gives some overview of the audit process. And we just want to point out there were no new accounting or auditing standards that were implemented during fiscal year 20. We had no difficulties in performing the audit. We definitely want to thank Lisa, Patty, Jeff, everyone at Central Health for their assistance, because it was a fully remote audit this year. So there definitely took a little more coordination to get through it all, but we definitely want to appreciate all their assistance that they gave us during the year. And then also there were no audit adjustments as part of our audit, and also no disagreements with management as part of our audit. Next slide, please. And so, as I mentioned, there were no material weaknesses in internal controls that were identified during the fiscal year 20 audit. Next slide, please. So I'll open up to any questions you may have.
Managers, are there any questions? I know we went over this last week in Budget and Finance. Any questions? I'm scanning and looking, but Manager Valadez, I think your hand is up, yes?
Yes, at last week's meeting, I began to ask questions and was told we'd have an opportunity to review this and I would be able to ask them at this meeting. I sent in some questions to our staff and was told by our esteemed attorney, David Duncan, that they were not relevant to this discussion. So I'll just make this comment, that when we're going to put information in the notes, such as the agreement, what is it, the hold fast or still, whatever it was, agreement, if they could give us at least a brief definition of what that is, because I had to call him and ask him what that was. I'd not seen that before. Also, to Jeff and Monica and Lisa, or at least our budget staff, those questions that I did send in, I would like to have answers to them. But again, I was told that they was not relevant to the adoption of the audit. So in light of that, I'd like to go ahead, if no one else has any questions, I'd like to go ahead and move adoption of the audit. I just wanted to make those comments.
Yes, thank you, Manager Valadez. They may have been relevant to the budget and not the audit, and I'm sure staff will address them. Manager Musaitif, did you have a question?
Mine is more of a comment. I just want to commend Lisa and Jeff and their team on a phenomenal job in completing this audit during these difficult and challenging times. I really appreciate all the hard work that you have done. Thank you.
Indeed, we have phenomenal staff and we have phenomenal financial staff. They are consummate professionals. Manager Valadez, did you want to make a motion?
Yes, I thought I did, but I move adoption of the audit as recommended by Maxwell by the firm.
There's a second. Okay, so there's a motion by Manager Valadez, a second by Manager Musaitif. All in favor say aye. Aye.
Aye.
Opposed, same sign. Any abstaining? I'm looking. Is anyone abstaining on this one? I'm not seeing any. All right, the motion passes. Thank you, members. We'll move now.
Chair Greenberg, this is Jeff Knodel. If you would indulge me in 30 seconds, I'd like to make just a few comments.
Absolutely, please.
Yeah, thank you for the opportunity. I'm Jeff Knodel. I'm Chief Financial Officer, and thank you for your support related to the acceptance of our fiscal year 20 audit. I'd certainly like to thank staff and the auditors also. I'd also like to just quickly walk through. There was a detailed article related to our audit this last week. I just wanted to clarify that what the auditors are bringing forward is a unmodified or clean opinion, which is again the highest rating that they can give audited financial statements. They're also bringing forward no deficiencies in internal controls. And in addition to that, no audit findings. And so that kind of leads me to the article that was printed actually specified that there were audit findings in our audit. And I just wanted to clarify there are no audit findings. What they were identifying as audit findings were simply variances from year to year. Any business in that produces financial statements will have differences from one year to the next. So I just wanted to point out there are no audit findings, and we appreciate the board's support on accepting this fiscal year 20 audit, and look forward to the next audit a year from now. Thank you.
Thank you again, Jeff and Lisa and all the other staff. I also noted that, and I appreciate you bringing that clarification, because you have met the absolute highest standards, the absolute highest standards. This was a clean audit, and that is the highest standard that you can have. Thank you very much.
Thank you, Chair Greenberg.
Anyone else? Okay, I'm not seeing, I'm neither hearing nor seeing anyone, so please shout out if I'm missing you. Okay, then we will move to item number 3, receive and discuss a presentation from Colette Holt and Associates on the Central Health Hub Disparity Study. Lisa Owens, again, and our consultant Colette Holt will be presenting, and I'm really looking forward to this. Thank you.
Wonderful, thank you. So as you know, one of the strategic initiatives this year is to continue to expand our outreach and contracting with historically underutilized businesses, or hubs, as well as to conduct a disparity study on our procurement activities. So if I may, first I'd like to just invite everyone to our community conversation tomorrow at 11:30 about how to do business with Central Health. We'll also be recording that and putting it on the website. But we will be presenting to the community and existing and potential vendors about upcoming solicitations and how to do business with Central Health, with a focus on our upcoming construction activities. Second, our disparity study is underway. It's my pleasure this evening, to introduce Colette Holt from Colette Holt and Associates. Central Health engaged Colette Holt and Associates in December to conduct our first disparity study. And as you'll recall, they are also conducting the studies for Travis County and the City of Austin, as well as others. They will be looking at our data from fiscal year 13 to 19, and we are in the process of collecting and sharing data with them. In addition, I'd like to take this opportunity to introduce Monica Montez, our new business process consultant who joined the finance team. She will be the study manager, and she will be our key point of contact. And many of you may know Monica from her 8 years on the eligibility team here at Central Health. So with that, I'm going to introduce Colette Holt, who's going to walk through the presentation and an overview of the study.
All right, well, thank you so very much, and hopefully you all can hear me. And thank you to Ms. Owens and to everyone at Central Health. I can certainly second the comments of your chair about the total professionalism of your organization. You have been a delight to work with, really, and we can't say that about everybody. So we are very happy to be working with you, and we are honored and happy to be able to provide you with this presentation this evening. And I'm happy to take any questions at the end. And someone there is kind enough to be my human clicker to make sure that all the technology works. So why don't we go to our first substantive slide, please. Just a quick bit of the team. I have been working on these issues for almost 30 years now. When I started out as an assistant city attorney for the city of Chicago. And actually the city of Austin was my very first client when I was hired by the law department in 1994 to take a look at an earlier disparity study for the city that council had raised some questions about. And the city has remained one of my best and longest standing clients ever since. Dr. Stephen Pitts is our economist, certainly one of the foremost African-American economists in the country, over 30 years worth of experience with minorities in the labor market. Stephen recently retired as the co-head of the Labor Center at the University of Berkeley and is now working on our studies full time. Joanne Lubart's our associate counsel. She also retired and decided she wanted to keep working. Joanne is a national expert on disadvantaged business enterprise programs, hub programs, and the like, and spent over 30 years in the general counsel's office at the Pennsylvania Department of Transportation. Glenn Sullivan's our director of technology, has decades of experience in Silicon Valley. I'm working as a project leader and data manager, and is responsible for all of our data collection and our website management. Next slide, please. Eileen Grossman's our assistant project manager, and those of you who are on staff, I've certainly talked to both Glenn and Eileen, and is our experience manager of disparity studies, has been working on them for quite some time. Victoria Farrell, Victoria Farrell is our anecdotal team manager, and is really working with us to ensure that we get good input from the overall community there. And lastly, we have Carol. Carol Borst is a very important member. She's the person that's going to be working on collecting data from prime contractors. Next slide, please. So there really were 4 objectives for the agency. The first one, and in some ways the most important, is to comply with the constitutional mandate that says that a local agency must have quantitative and qualitative data that supports its need to have some type of race and gender-based program. Some of you may know that the federal courts are extraordinarily hostile to these programs and really do require this level of data collection and analysis in order to support the agency's desire to have some type of a hub program. We also think it's important that we give you accurate data so that you can set an overall annual objective for your spend with historically underutilized businesses, as well as set narrowly tailored, reasonable, and achievable contract goals. You may have, let's just pick some number, a 20% overall goal, but in any particular contract, that might not be the right number. So we will be providing at the end of the study as a deliverable, highly detailed data that will allow you to set narrowly tailored contract goals. We also want to use the study as an opportunity to gather feedback for the development of your program. In some ways, you really have an advantage over many other agencies that have the long legacy programs like the city, in that you get a chance to start with new and fresh ideas and work off all of the things that we've learned in the last 35 years of working on these programs. But we, of course, need to talk to the community, the contractors that you particularly deal with, to make sure that what we might propose and what you might decide to impose really works for everyone. And lastly, we try to use the study as a tool to educate everyone about the issues. Disparity studies are really the offspring of lawyers and economists, and that can be some pretty thick going. So we will have an executive summary that is accessible to everyone that lays out the data, the methodology, the findings, and the recommendations. Next slide, please. So what are the elements of the study? Well, we have a study website. It is up, it is live. Please do visit us. And it is a way for us to both inform the community as well as get any public comments or feedback, and they can contact us that way. We will have a chapter that has a legal review of the standards so that should you be challenged, we would be able to point to that chapter to explain to a federal judge what we believe the law to be and how our methodology fits within it. Then next, turning to your utilization of MWBEs, and this includes hubs. We have a broader definition than just anyone who's certified with the state hub program. So that's why throughout the rest of the presentation, you'll see the term MWBE, which stands for Minority and Women Business Enterprises. So we will be looking at your utilization of those firms as a percentage of all the dollars you spend. As Ms. Owens mentioned, the study period is 2013 to 2019. That is a good long time. So we will be able to present a in-depth picture of your contracting that smooths out any particular anomalies, or some years you might have had a lot of really big contracts, other years not so much. So this way we can get a good snapshot. So our first step is to gather your prime contracts to create our initial contract data file, and we are well underway in that process. Next slide, please. Our second step is to gather any data that are missing from the agency. You all have never done a disparity study, and so our expectation is that there will be some back and forth as we are able to gather all the information that we need. Then our third step will be to go to your prime vendors, and it isn't just construction, let me stress, we're doing other industries as well, to collect any data on subcontractor utilization that may be missing in your records. Very few agencies have all of the subcontractor data. We've only really never seen it, but even to get 90% is very rare. So we're used to doing this. It is our responsibility, not yours, and we will make sure that we do it. We will collect at least 80% of the contract dollars. We usually get well above that. I believe for the study that we recently conducted for the Texas Department of Transportation, I think we were well above 95%. So Carol Borst, Glenn, they are relentless, and they will just stay on it until we get it. Once we get that information, if race and gender ownership are missing, we will assign it, and we will assign any missing industry codes. And NAICS stands for North American Industry Classification System codes. These are developed by the U.S. Bureau of the Census, and they are in wide use throughout all different kinds of economic analysis. But it is important that we give you data that are disaggregated. Sometimes studies will provide estimates of professional services. Well, that might be okay at the annual level, but if you're trying to set a goal for a specific contract, that is way too broad. So we will be assigning that highly detailed data. Once we've done that, the courts require that we determine what the geographic market is in which you operate and the product or industry markets from which you purchase. Now, it may turn out that the Austin metropolitan area is your geographic market. Might well be, but it's an empirical question and we just have to go count. And so we will determine that based on where at least 75% of your dollars are spent. We do it by unit of measurement of counties, and we make sure that the counties are in fact contiguous. So we'll figure out your industry market. We'll analyze the data for your prime vendors, for your sub vendors, and for prime and subs combined. And then we will figure out what is your geographic market within that product market. So it's really we have 4 steps, but these really are several steps underneath it. And then we'll be able to provide you with detailed utilization data by race, by gender, and 6-digit codes. So should the board, for example, want to know what is the utilization of Hispanic architects or engineers, we will in fact be able to tell you that. Next slide, please. So that's your utilization. To put it kind of colloquially, that's who got the money. But we also need to figure out who was available, who could have gotten the money in your markets. So we really have 3 sources for this. The first is a master list of minority and women firms that we will create from various entities. One thing that is good for you and certainly saved you some significant money was the fact that, as was mentioned, we are doing the study for the city, for Travis County. We just did TxDOT, and so we have a lot of these lists already developed. So that will be a relatively simple thing for us to do. We'll also take any information that's in your contract data file. There may be minority and women-owned firms that were in fact utilized, but are not on one of these certification lists. So we'll take a look at that as well. And then we use as our overall business universe, Dun & Bradstreet, which is Hoover's now. And we like this data source for a couple of reasons. One, it's very comprehensive. It is by far the most detailed, reliable source of business information that you can get. It's also reasonably current. It's about 90 days or so, and that from a researcher standpoint is very current. And we also like it because federal judges like it. You see Dun & Bradstreet data used for all kinds of business research and litigation. So we could not be accused of some type of juicing or manipulation of the data for purposes of the disparity study. So once we've done that, we will estimate detailed weighted, oh, I'm sorry, the cat runs the world. There you go. Detailed, unweighted, and weighted availability. And we can combine and disaggregate that by race, by gender, by industry codes, any way that's useful to you. Next slide, please. So now we have our utilization information and we have our availability estimates. And now we can engage in the disparity analysis that the courts require in order to support a hub or MBE or DBE type program. Disparity analysis is really a very simple idea. We have some equations, but the concept is really very simple. It is how tight was the fit between who was utilized and who was available. And so you see there, it's a very simple ratio. The courts have told us that if you get a ratio of 80% or less, that can support an inference of discrimination. We'll also be taking a look for statistical significance and we'll apply confidence intervals, so sort of standard regression analysis. And we'll be able to do that for all of your race and sex groups and the industry groups combined and disaggregated. And I think that you have not really been setting goals, so we think that there won't be contracts with goals, but we weren't sure, so we just wanted to make clear that we will be looking at both types of contracts. Next slide, please. So that's an analysis of your own contract data. But it's also useful to have an economy-wide look where we take a look at what's going on in the overall Austin area economy. And this has been very useful in defending these types of programs because we're able to say to a judge, well, Your Honor, maybe the agency's doing pretty well, but overall minorities and women are not getting their fair share in the overall economy. And so that can be a basis for having a program. So we'll be taking a look at 2 Census Bureau databases. There's the annual business survey, which looks at firms, and the American Community Survey, which looks at individual entrepreneurs. Next slide, please. So that's the quantitative data. But we also want to look at qualitative or anecdotal data where we talk to real live people about their experiences. Again, one advantage that you have is we will be gathering extensive anecdotal data as part of the other studies. And I think I've conducted 20-something sets of interviews already for the city, and we'll be doing more for the county. So that will be a data source that we will use for you as well. But we also thought it was important to have targeted small group interviews with firms that are specifically involved in your industries. We will divide those into minorities and women and non-MWBEs because we found through experience that if I put everybody in a room together, they're all going to sing Kumbaya and tell me how great everything is. But if we separate them, we are often able to get much more candid feedback about what their issues are, which you see there below. So we'll be asking about barriers to doing central health contracts, any barriers out in the marketplace, experiences with discrimination. Are they able to access prime and subcontracts? And also what possible measures might help them that are race and gender neutral. And what I mean by race and gender neutral are things that would help all small firms. So for example, making sure that the agency pays promptly. And by the way, thank you. You all paid your bill very, very timely. We appreciate it. Experience requirements, insurance, those kinds of things that can be a barrier to all small firms, which will benefit hubs, but will also benefit the larger marketplace. So we think those are important things to ask people about. Next slide, please. So once we've done all that and we have our findings, we will make you some recommendations. We tend to group them into 2 types. The first are those race and gender neutral measures I was just discussing. And then if the data support using race and gender-based remedies and having a fully race-conscious hub program, then there are some issues that will need to be addressed. For example, who's eligible to be in the program? The courts, again, take a rather jaundiced view of all of this, and so it's important that we have data on all of the different groups. What kind of contract goals can you set? How are you going to evaluate bids and proposals for compliance with the program? What type of contract monitoring and performance policies and procedures should you employ? And then last but certainly not least, what kind of data collection and monitoring systems might you think about? Next slide, please. So how can the staff assist and the board members? Certainly to the extent that you have interaction with contractors that do your work or vendors, we certainly would like to get those names from you. We will see people in the contract data, of course, but if there are businesses that you think would be particularly important for us to talk with or that would have good feedback or information for us, please do help us to figure out who those folks are. To the extent that we have some prime contractors that are non-responsive to our request for information, we may come back to the staff, whoever was the project manager, and ask for a little nudge, just a phone call. We don't want you to collect any data. That's it. Just make a call to say, look, this is important to us as an agency and as your client, And we would really appreciate it if you would cooperate with these people. And then finally, encouraging the community, contractors, stakeholder groups to participate in the study process. We really do want as much input and as broad participation as possible. Next slide, please. So here's some information. There's the website. It is live, so please do check it out. We have a dedicated study email and a phone number. You can certainly do that. You can email me directly, or you can contact Ms. Montez, who is our study manager, as mentioned, and we will be happy to get back with you and answer any questions that you have or address any concerns that you have. And I think that's it. Okay, so I'm happy to answer any questions anyone may have.
Thank you so much. Excellent presentation. I am so impressed with the presentation, with your methodologies, and of course with your deep knowledge in this area, and excited that this work is commencing. I want to open this up to any questions that board members may have. Again, I'm scanning, but if I miss you, just get my attention, shout out. Manager Valadez.
Thank you all. Thank you, Colette, so much for the presentation and for your introduction of the participants from your team, I guess, to us as a board. Will you all be asking board members for any information, or is it just open to the public, or whoever you all have targeted for contacting?
Well, certainly when we're doing the interviews, we do want to talk to vendors, people who are business people who sell what it is that you that you purchase. We're happy to talk to board members. I will tell you though that the courts, again, are just so hostile to these programs. And one of the things that they seem to be very concerned about is any type of political interference or insertion. The case that started all of this was the city of Richmond, Virginia, versus the Croson Company. And in her plurality opinion, for any of the lawyers that are on this call, there are actually 5 opinions in this case. But in Justice O'Connor's plurality, she seems very concerned about quote unquote racial politics might be part of the reason for the program, which is, at least as a side note, is a rather astonishing statement when you're talking about the capital of the Confederacy that up to that point had never awarded a contract to a Black contractor. So, okay. But we have to play by their rules, and certainly the federal courts are probably more conservative than they've been in my practice lifetime. So we need to be very concerned about that. We're certainly happy to talk with you if you have concerns, or if you know of vendors that you think that we should contact. Please do let us know that, because you are a big player in Austin, but you also have a more unique mission. I mean, you're not the city, you're not the county, you have a much narrower focus, and we want to be sure that we pick up those vendors as part of the study.
I appreciate that. Thank you. And I want to tell you that I'm very pleased. I told our CEO today that were he not at the helm, we would not be indulging, we would not be participating in a disparity study were he not at the helm. Because when we advocated for this the last 2 times that the city and the county were involved in this, I personally was one of quite a few people that came before Central Health Board, long before I was ever on the board, to advocate that they take this action and participate. They did not. And so I just want to commend our CEO and our board for moving forward with this disparity study, participating in the disparity study, and wish you all the luck. Anything we can do to help you, I appreciate it. Thank you.
I appreciate that too. And one thing we appreciate is that the CEO, senior staff has made it very clear to everyone that this is a priority. And it's just so important in the research, because sometimes we have clients where somebody's agreed to do this, but nobody really seems to care. There's no top-down input, and that's definitely not what's happening here. So as I say, you've been a wonderful client to work with, and we're really excited about this project.
Thank you.
Well, thank you. As Manager Valadez noted so eloquently, this certainly is a priority, and we are really happy that we have been able to begin this process, and we appreciate your database evidence and data-based approach also. Thank
We're
you.
data jockeys, basically. So
Yes. And given the requirements of the court, I feel that that the evidence and data-based methodology will stand us in good. Thank you. Other questions, members? I'm scanning. I'm looking. I'm not seeing any or hearing any. Well, if that is the case, there is no motion necessary, and we thank you for your time and attention. Mr. Mike Giesel.
Yes, thank you so much, Chair Greenberg, for recognizing me, and I appreciate the comments earlier. And I will say there are a number of advocates, both internally and advisors externally, that have been supporting this study, and we're so excited that the work has commenced. And on behalf of everybody at Central Health, we want to be as participatory and as helpful as we possibly can to make this a successful study. And we look forward to it. Thank you.
Thank you so much. Anyone else? Well, again, thank you, Colette. We appreciate you. And we appreciate
Good night, everybody. We will be in touch, and hopefully we can maybe be together at some point. I'm just down the road in San Antonio, and I can't go there. I mean, what are you going to do? And by the way, thanks to all the healthcare workers and everything that they're doing. I mean, it's just so critical. Thank you.
We appreciate you.
Good night, everybody. Thank you.
Good night, Colette. Thank you very much. Okay, so we will now move to agenda item number 4, receive a report on fiscal year-to-date healthcare service expenditures made by and accept the preliminary December 2020 financial statements for Central Health and the Community Care Collaborative, and review historical average revenues and expenses for Central Health. Lisa Owens, you're on deck again. Lisa Owens will be presenting. Thank you, Lisa.
All right, good evening. Okay, well, I have our preliminary or our unaudited December financials. Let me share my screen. A couple presentations, so I'm going to kind of flip back and forth for you tonight. So for Central Health, we are in the thick of tax collection. You'll recall the tax deadline is this weekend. So as of December, though, that was 27 days ago. We were at 90 million compared to 92 million last year. So I think we talked about this last week. We have been tracking that just to make sure we don't have any concerns about collections. And it really does seem that people are just waiting until that deadline. But the tax to date, I checked with our team today, is tracking about $10 million ahead of last year. Which you'll recall we estimated an additional 20 million in taxes this year. So we are on track to be very close. As you remember, in February, we have some more tax revenue come in, and then it starts to dwindle down throughout the fiscal year. So we are tracking that as we move forward. So as we look at the balance sheet, whoops, wrong button. I will just quickly highlight again, we did start the year in a strong cash position, and you'll see that we had taxes receivable. We do, taxes are due, and that levy is due to us at the beginning of the year, so it is fully recorded, and then as the dollars come in, that receivable is relieved and the cash is recorded. And we also, so we are in a very strong position going in December. We also continue to have funds for the LPPF, 8.6 million at the end of December, and that brings us to total assets of 653 million as of the end of December. The balance sheet, you'll recall we have a fairly low percentage of current liabilities generally. However, that deferred tax revenue is there that is due, and so as that is coming in, that deferred tax revenue is part of our current liability. So those numbers will change pretty significantly as we go into January and February. Total liabilities of 189,000, and then total net assets of 463 million. Our total sources and uses through December, we again had $88 million in tax collection, our strongest collection month year to date. A total of $92 million in sources of funds. And year to date, our healthcare delivery is about 23 million, and our administrative expenses at about 1.7 million. So our total year to date uses is at 25 million. I'm just going to hit the highlights tonight on healthcare services, as we're fairly early in the beginning of the fiscal year, and this additional detail on the different specialties are available to you tonight. And I know we have a lot on the agenda tonight, but I'm happy to answer questions tonight or offline. But our primary care, specialty care, both tracking fairly consistently with last year. If you look at the year-over-year numbers, we are at approximately $15 million in total healthcare services. Much of that, again, being in primary care services and our pharmacy dollars. And then our premium assistance program, you'll recall in December or January 1, new enrollees will come into that program for the ACA premium assistance that was expanded this year. So we will start to see additional expenditures there year over year, but at about $2.8 million through December. And then a total healthcare delivery again at 23 million. I'm going to skip over the healthcare delivery, and can you see the dashboard? Just making sure I'm navigating right.
Yes.
So this is our dashboard year to date, just kind of hitting again on what I talked about. Our net assets continue to trend with cash coming in and our sources of funds. As we see the tax collection come in, this is our peak in January, so we anticipate that happening again. But I did want to talk through a little bit about, as we've changed our participation in IGT programs and with the development of the LPPF, we are going to start to see our uses of funds become more of a steady expenditure. And that's what you're seeing here, this variance as we go throughout the year. Now we will see more expenditures in primary and specialty care, but it will continue to be more of a less peaks and valleys as we move forward in our new contracts, and as the IGT is not transferred for, I think this was probably uncompensated care. Well, actually that was in the LPPF. So as those IGTs are really just going to be next July in the DSRIP program. So really quickly, speaking of the DSRIP program, I'm going to switch to the CCC, and I hope you can all see that. Just a few highlights on the CCC. Continue to be fairly steady with last year. If you look at prior year to date, these are presented in the year to date mode for our new board members. So this is year to date through December. $22 million in assets, just about $3 million ahead of last year, and mostly in cash. And then our liabilities are in accrued liabilities. We'll talk a little bit more about that. The deferred revenue is reserves for DSRIP, deferred revenue that has been received that we are reserving in case any audits have any findings, which we have not had. And then our net assets at 11.5 million, and total liabilities and net assets again at 22 million. Year to date, in the CCC, our source of revenue is going to be in interest and investments earning. We do have the operations contingency carry forward there of about $11 million. That's reserves available from the previous year that are carried forward as a source of funds for the current year. Healthcare delivery, approximately $3.4 million in that, and then our DSRIP project at $1.3 million year to date. Just a few more details on our healthcare delivery. Looking at that, we have primarily the specialty behavioral health as the largest budgeted item in there, and specialty care and all of those at about 18% year-to-date budget on $3.4 million of our $19 million budget. So with that, I'm happy to answer any questions on either Central Health or the CCC.
Thank you, Lisa, for that thorough presentation. Members, questions?
I'm going to stop sharing for you.
Yes, thank you. It's easier to scan that way. Members, do we have any questions? Manager Musaitev?
Yes, thank you, Lisa. Appreciate it. If you can go to community care's slide, last one, year to date, is there a way you can send me or whenever it's convenient to you, comparison of what last year compared to, I just wanted to compare it to see if this pandemic had, what impact did the pandemic have on these services? So that's really the question that I'm looking for.
Oh, in the healthcare services for Central Health?
For community care and Central Health. I think they're all under community care, aren't they?
Yeah.
If I may, Madam Chair, this is the Community Care Collaborative. This is the CCC.
Right. This is the CCC. This isn't community care. But I do believe, Mr. Beacon, that we have had some presentations from Jason Fournier talking about this in the past few months, haven't we? At some meetings?
Yes, and also we have summary, and I'll have to go back and look at the cadence, but we provide summary information both for Sendero and community care in terms of what their financial performance has been. It's a summary document that's been in prior board.
And if we could,
we'll continue to do that throughout the year so that you can see the impact.
Thank you, my brother.
And if we could look back, I know we had a meeting. Time flies. Sometime over the past few months, where Jason.
It's been a while.
Yeah, presented some slides. Maybe we could see if he has updates on that.
I would appreciate that. I would want to see what the impact is. Thank you.
Yes. Those were when we had the discussions about rapidly, our patients moving to telemedicine and telehealth and telephonic. He talked about that and other repercussions. So, Mike, if you could see if he has updates as to what has been happening during the pandemic as we move forward, both with, I guess, modalities of care and also, I think, comparing that to last year and the budgetary implication vis-a-vis last year. Thank you.
And while you're doing that, if I may, I'm not sure if this is the right format, but I'm also interested to see how many have missed their well visits during this period of time.
That would.
So that's really, I'm not sure what the right format is. That's something.
We will craft. Yes, Mr. Giesler.
Yeah. Because this is posted as a regular financial reports update for Central Health and the Community Care Collaborative, we need to bring that back in under a future agenda item.
I think that's
correct. Thank you.
Yes. Manager Valadez.
Rom, are you through?
Yes. Manager Valadez.
Yes. I did send some questions to them that I think that would be pertinent or relevant to this discussion. Lisa, if we can have an offline conversation with respect to this, and I can bring them up later on. But I did send you those questions, and I appreciate answers for them. Okay. I would like to see thank you very much, Lisa. I would like to see a community care budget for the year. Unless are they pending?
I think we're on, Manager Valdez, we're on the Community Care Collaborative now, right, Mr. Giesland?
Right. So, I understand. This is a request also.
Okay.
For
a future agenda. Yes, we'd have to have a
future agenda item, and at least forwarding to us as board members.
Thank you.
Especially so that we can look at perhaps any expenses or differences and comparisons, between last year and this year.
Thank you. Managers, anything else on Community Care Collaborative? Okay, or on this agenda item? If not, we will move, not seeing or hearing any other questions. So seeing and hearing none, we will move to agenda item 5, which is receive and discuss the following focus reports related to the strategic objective in section II1.B. of the resolution adopting the fiscal year 2021 budget. A, current workforce demographics and levels, including new hires and turnover. And B, training and development initiatives. Susan Willers and Angela Reyes will be presenting, so we'll turn it over to them.
Madam Chair, if I may,
Yes.
could we kindly ask everybody that's joined the board meeting
Yeah,
to
if you're
please
not
mute your
mute.
calls?
Yes,
your
I'm hearing a lot of
computer.
background noise
Thank
too. So if you're not speaking, please put it on mute. Thank you.
Thank you very much.
Thank you. Good evening, Board of Managers. My name is Susan Lara Willers. I'm the Vice President of Human Resources. Before I begin the presentation, I would like to introduce to you our new Diversity and Inclusion Manager, Jana Allen. Jana has been with Central Health since 2019. In her previous role, she worked as a program manager in the Community Engagement Department. As the new Diversity and Inclusion Manager, she will lead the execution of Central Health's diversity and inclusion strategy, and she will serve as a catalyst to leverage best practices to promote a culture of awareness and inclusivity. Jana, just wave hi so everybody knows who you are.
Jana,
met you.
Jana, we appreciate you and we thank you for taking on this new role. Thank you very much, Jana. Susan?
Thank you. Thank you, Jana. I would also like to introduce to you our Enterprise Senior Recruiter, Angela Reyes. Angela is one of our 2 recruiters with our enterprise. She has been with Central Health 2.5 years, and she has over 20 years of experience in recruitment. Angela will be sharing the following presentation with me. So I'm going to be sharing my screen here with you all. Just bear with me.
And thank you, Angela, and thank you for being with us this evening.
Okay. I'm hoping that you all can see my screen.
Yes.
Okay. The PowerPoint.
Well, good afternoon, everyone.
Yeah.
It's our sincere pleasure to go over with you all the Human Resources Recruitment Strategy Plan. Next slide, please.
Angela, if I may, just as an introduction, as promised from the previous meeting, we are going to discuss with you this evening really the recruitment efforts that our recruiters, our recruitment team really has conducted in the first quarter of 2021 based on our recruitment strategy plan. I do want to say, and I interrupted you, Angela, because I'm very proud of our recruitment team, both Sarah Willingham from Community Care and Angela as an enterprise employee. What they have done this past quarter is remarkable, and that is what we're going to share with you this evening. So, Angela, I'll turn it over to you.
Thank you, Susan. As Susan has explained, this is the first quarter that we have completely transitioned over to our recruitment strategy plan. The Human Resources Department has one goal in mind: to attract and retain candidates from diverse backgrounds that reflect the members of the communities that we serve. Next slide, please. Well, we are focused on establishing our employer brand to attract and retain top talent by providing a great place to work, becoming known as a quality performer in our industry, and to be recognized for our commitment to diversity and inclusion. Our second component is that we are enhancing our talent management efforts by developing partnerships with Texas colleges and universities, especially those identified as having a diverse student and alumni population. Our plan is to increase our visibility in both academia and the community. We are consistently attending a wide variety of career job fairs that promote the enterprise and our existing vacancies. We will track these measures on a quarterly basis. Next slide, please. This multi-pronged approach It's geared towards targeting diverse and traditionally underrepresented candidate groups. Our focus is in direct messaging to candidates for diversity and inclusion with all these efforts. And we began tracking these records back on October 1st of 2020. Next slide. The graph above contains career fairs. It contains some of the events that we've had messaging and events locally and via social media. They're all career focused. Last quarter, the team also developed a careers newsletter for monthly email communication to college and university career services, alumni association, and diversity and inclusion groups. Now, Susan Willers will continue to provide you insight into our metrics for the first quarter of 2021.
Thank you so much,
Angela.
Thank you, Angela. So the information on the following charts that I'm going to be sharing with you has been updated from the packet that you received. We removed, what we changed was that really we removed one column of those applicants that chose not to disclose their gender or race and ethnicity. Therefore, the numbers have changed, and we will make sure you get this packet after the board meeting tonight. The next few charts will reference the EEO4 categories that you see on this slide. The EEO4 categories are categories that the EEOC requires in tracking positions as part of our EEO4 biannual reporting. As a reference, the categories that we will review tonight will include officials and administrators, and these are just examples provided by the EEOC of positions that fall under officials and administrators, professionals, social workers, doctors, RNs, accountants, etc. Technicians are computer programmers, technicians, medical and dental assistants, as an example, and administrative support are clerks, payroll clerks and cashiers. So the first, I'm going to highlight 2 of the 4 categories that are in your packet or that you'll receive tonight. These 2 categories had remarkable increases in activity from Q4 2020 compared to Q1 2021. So I'd like to start with this first category of technician. This is a pretty busy chart, but if you look at this top part, this is Q1 of 2021, and the bottom half is Q4 of 2020. In 2020, we had 13 positions under the technician category, and in 2021, Q1, we had 8. As Angela mentioned, we are now tracking the sources, and so this was the activity that, you know, people disclosed how they heard about this position that they applied for, and they provided us with this information. So we had 428 applicants in 1 quarter for these 8 positions. The following information here, what you see in black are the applicants that reported themselves as male, and then the breakdown in race and ethnicity, including what is in orange, which are the females. And same thing, you'll see the breakdown. The totals are really just the totals for males and females, and then the percentage is the percentage as per the 428 applicants. So in this example, we had 159 applicants that reported themselves as white. That was 37% of the 428 applicants. What you see on this column here is the breakdown of the candidates that we hired. We went ahead and included internal candidates and bolded that just to let you know that these individuals were hired internally. So 2 of the highlights here is, and then down here you'll see the same type of calculation. So something to note, we had 179 or 58% more applicants that were reached in Q1 2021 compared to Q4 2020, with 5 less positions. Also, we were able to add 34 more minority applicants and 36 more females in Q1 compared to Q4 of 2020. The next category
Susan,
is,
you meant 30, you meant percent, right? Those are not
sorry,
gross numbers, 34% and 36%, correct?
yes, thank you so much, yes.
Mm-hmm.
The next category is officials and administrators. And we have the breakdown exactly the same. Things to highlight is that we had 19 or 33% more applicants that were reached in Q1 of 2021 compared to Q4 2020. We were able to add 39% more minority applicants and 36% more females in Q1 2021 compared to Q4 of 2020. Also, both candidates were internal candidates that were promoted into these categories. So these are really the highlights that we wanted to share with you today. Every quarter, we will be presenting this breakdown of EEO categories and really highlighting the work that our recruitment team is doing for that previous quarter. And so with that, we'll turn it over to you, Madam Chair, for questions.
Thank you. Can we leave the PowerPoint? It might be easier to have a discussion that way.
Yeah.
Thank you. Thank you. I really appreciate you providing this information and the hard work of your staff. And I want to note those substantial percentage increases. Those really are to be noted. I'd like to open up to any questions from the board. Questions from any of the board members. Manager Valadez.
Susan, thank you for the presentation. And I know y'all are doing a lot of work, but with respect to the reports that we got tonight, is there a way to tell us what the total is so we'll have an understanding of the context of the information? You know, if you have you know, in FY, you know, the last quarter of 2020, you had, let's say on the technicians, you had 13 or 14, whatever it was, and first quarter you have 8. Well, of how many, you know? So, you know, do you have 50 technicians? Do you only have 20 technicians? You know, that's the kind of information I'd like to be able to compare. And if I just have that information, I don't know what the total is, so how can I do a comparison? I don't know if I'm making any sense, but I'd like for you to tell me if I am or am not.
Oh, okay. Well, let me just make sure I understand. So you're wanting us to compare that total to the number of current employees in that technician role?
In that field, yes.
I see.
So that we can get have an idea as to what that means, what the numbers are meaning. I don't know if anybody else sees it that way, but maybe that's just the way I see it.
And Manager Valadez, the next presentation, I think we'll touch on that. We're going to share with you the diversity dashboards. So that may help, but if it doesn't, we will definitely look into providing more information.
I appreciate that, just because when I'm looking at the information on the 2 reports that you gave, and it looks like of the 8 positions you had in the first quarter of 2021, you only hired 1 female out of 8 technician jobs. And you know, in my head, that raises a question. So I'd like to, if I had totals, you know, based on, you know, either race or ethnicity and gender, you know, I might be able to see, and I don't know what the job description is either. So with respect to the jobs that they do, how am I going to be able to determine for myself whether or not that's a significant change or not? So that's just my input. Thank you.
Manager Musaitev.
Thank you, Chair. Thank you so much for the presentation. Given that we're right now in a pandemic, and I know we can't be feasibly in person for career fairs, and how can we really do more targeted intervention, like Zoom meetings to like targeting HBCUs, colleges, to meet and connect and talk to them about what opportunities we have, the benefits and everything that I think that would be really helpful to building that connection with our local community. I know LinkedIn, I noticed that profile significant amount of applicants as well, but it really helps if we kind of build this kind of relationship, that openness in our community. And I know we have a major schools here and 1 great HBCUs, but so I would really encourage us to do more targeted interventions to increase our profile. So that's really my comment. Thank you.
Thank you.
Can I comment about that?
Yes, please.
Yes. Due to the pandemic, all events that have been scheduled really since the spring of last year have been virtual. We have therefore scheduled stakeholder calls, Texas workforce, job seekers. We just had an event this month with the Texas Workforce Commission for candidates that were over 50. This month, we will also have a Veterans Career Fair with Texas Workforce Commission, and that is scheduled for 1/28 of this month. We will be having an internal career fair scheduled with Community Care this Friday. This month we have promoted over 8 jobs via handpick with 27 colleges and universities in the state. We are doing a monthly newsletter. We are promoting individual LinkedIn posts. For example, we just posted a position 2 days ago for a security engineer with IT, just to give you an example. And we are having more events locally. With UT Austin, for example, we are participating in a virtual nursing career fair on the 12th of February, just to give you an example of all the things that we're doing. And as a recruiter, we only have seen it snowball. So we reach out, we have a session with one of the colleges and universities, and we get more invited to more and more events. Thank you so much.
Well, thank you for that. But I would also go back, if we can really reach out, have more targeted intervention with HBCUs in our local community. I would really appreciate that. And also advertising it. I know Ted and his team are doing a phenomenal job, but more around our social media, as you mentioned, it's a snowball effect, and really it's a word of mouth. And we need to diversify our workforce. Thank you.
Thank you. Managers, any other questions? Manager Motwani, yes, please.
Thank you, Chair Greenberg, and thank you for the presentation, Ms. Willers and Ms. Reyes. I don't know if you might be able to put the PowerPoint back up. What I'm looking at in the packet doesn't have some of the statistics that were cited there. And while we're doing that, wondering how feasible it might be to, as we're looking at sort of the journey from recruitment to, hire, we're seeing how many applicants we have, we're seeing how many hires we have. And I certainly don't want to belabor this by making this gradient too granular, but would it be possible, is it feasible at all in any way, form, or fashion to have some sort of snapshot on how many folks are achieving interview, if that's an appropriate sort of middle step in this process? I feel like it might add some more dimensional context, but I certainly understand if it's infinitely regressive in as much as how much work it costs to be able to get the juice from the squeeze. So that's my first question. And then I'll follow up with questions around the statistics that I'm seeing on the bottom there.
Thank you for the, yes, thank you for the question. I think, so just to kind of go back to the purpose of this exercise or the recruitment strategy, it's really to increase the number of applicants in the applicant pool. And so what we were struggling with in the past is that we really did not have a diverse applicant pool. And so our numbers, were low. And as a result, we really couldn't hire folks from underrepresented areas because we weren't reaching out to them. And so that was the number one purpose. But I see what you're asking for, and I will have to get with Angela and figure out if we can do that.
Oh, yes, ma'am. We can do it, and we can.
Perfect.
Thank you, Angela. And Manager Motwani, I believe you had a follow-up question.
Yes, and thank you so much for having answered that question. That makes sense. I guess the KPI was the applicant pool, and then once we feel like we've achieved that, perhaps a secondary goal, maybe looking at that journey and how we may be achieving along that journey, opportunity toward hire. And if we're looking at more applicants reached in Q1 2021 versus Q4 2020, could you I don't know, could you put a finer point on that? Are we saying we reached more minority applicants, or just more applicants in general were reached? And I'm just wondering if we can get a finer point on that, and if we're assuming that that is a result of outreach, or sort of better outreach, or if it's a function of anything else, maybe economically or holiday wise. If you have any sort of insight as to what the causation is.
Sure, that's a great question. So it's both. It's the increase of applicants, number one, and then also as you look at these notes over here that I highlighted, it is an increase of minorities in the applicant pool and females as well. And so we do attribute some of this to the outreach efforts that our recruitment team is putting together. And as Angela stated, I mean, the plan that the recruitment team has put together, and we'll make sure that the new board members get the recruitment plans, the recruitment strategy plan, but it outlines just months and dates of everything that will transpire throughout the 2021 year. And so we think that's why we're tracking it now, is we want to make sure that as we're going out and conducting these fairs, that we're able to track the success of those by the folks that are applying for these jobs.
To be clear, the increase in minority and female applicants, is that is that an increase sort of apples to apples, meaning increase of the total applicant pool for that month, or is that an increase of just, are we, female and minority applicants in month one, and so rather, forgive me, in quarter four versus total female and minority applicants in quarter one? Is it relative or is it absolute, I guess is the question.
Yeah, and I didn't capture all of your question, but if I understood correctly, are you asking if
well, while you're off and while you're on live duty, you should go get that.
Hello, somebody needs to mute, I think. Continue, please.
Okay, so you're asking if the increase of minorities and females, is that within that quarter? Is that what you're asking?
Yeah, so, meaning if we're looking at, more, let's just say female and minority applicants, as a group, are we saying that, there were more female and minority applicants as a relative proportion, as a relative percentage of the applicant pool for that quarter, versus as a relative percentage of the applicant pool for the compared quarter? Or are we, are we looking at a total versus a total sort of deal?
Yeah, no, that's correct. It is relative to that quarter and for that EEO category group specifically.
Thank you so much.
You're welcome.
Thank you. Any other questions? I'm trying to scroll down here to see. Manager Valadez, I think you have a question. You're on mute, Manager Valadez.
If you could lose the screen for a minute so I can see you. Thank you.
We're back to our squares. Here we go.
Oh, thank you. Perhaps, Susan, it might be helpful if you could provide from beginning to where we're at right now, how we started out, how we came to this point, to this conversation that we're having in trying to change how Central Health does business, so that we have a diverse workforce that's representative of our population. If they're new board members, they wouldn't have that background, and it would be great for them to have that so that they could see how we're changing, Central Health is changing to look at incorporating a more diverse workforce.
So Parallel, let me suggest that we include that in the orientation materials, because I do think that's important background, and the whole discussion, as Ms. Willers and Manager Valadez were stating, that we realized if we didn't have a more diverse pool, then we weren't going to make progress. So we really had to do that kind of outreach and continue to, and as you said, with the key performance indicators, track it to see if we in fact are having a larger and more diverse pool, not just larger, but more diversity, hopefully both, a larger pool and a more diverse pool.
And I want to make one background comment to our new minorities. Our new members. When I first came onto the Central Health Board 5.5 years ago, it appeared as if we were almost in incestuous relationships with the other entities, city, county, UT, Seton, and Central Health, passing people around from entity to entity. And so it was very difficult to achieve any diversity or expand outside beyond your circle or your of partnerships. And so this is one of the things that I was concerned about. And I'm very glad at the efforts that Susan and that Mike has allowed for his team to do in understanding the need to expand the quality, the quantity, and the diversity of our workforce. So thank you.
Thank you. Members, anyone else before we move on from this item? I'm not seeing any hands or hearing any voices wishing to speak. So if that is the case, thank you very much to all the staff, and thank you to all the board members for the robust and very informative conversation. We will continue to be working on this diligently, and I know staff is continuing to increase their efforts and using all of the online and virtual and Zoom meetings we have for meetings and career fairs and whatnot. And we will continue to track these key performance indicators. And I think that we will be devising new KPIs as we're moving on through this process. Absolutely. Thank you. Okay.
Ms. Greenberg, I have a second presentation.
Yes, Susan, I thought you did. Those were the dashboards you were talking about, right?
Yes.
Perfect.
Okay. Thank you, Angela. Let me share my screen very quickly, and I'll quickly introduce Betsy. Okay. All right. Let me move you all over here. All right. So now Betsy Good, and those of you that are new, Betsy Good has been with Central Health over 1 year, and she serves as our Human Resource Information System and Compensation Analyst. And she's really the person that really does all these wonderful graphs and dashboards for the Human Resources Department. So
hold on, Susan. I'm just going to ask everyone again. I know it's hard to remember. If you're not speaking, please mute yourself. Thank you.
Thank you. And Betsy and I are going to be sharing this presentation as well. For some background information, the HR department has been reporting workforce demographic data for over 1 year. However, in November, we introduced a new format. Tonight, Betsy and I, this was introduced back in November. So tonight, Betsy and I will speak to the 4 dashboards. And as reference, the 4 dashboards include headcount and tenure of the enterprise staff, the voluntary turnover for the enterprise and Central Health proper, the Central Health proper diversity numbers, and Central Health's proper diversity EEO distribution by category. And so I will start us off by just sharing with you, this is the first, I'm hoping y'all can see my screen. Yes? Okay.
Yes, we can.
Okay, so this is the headcount demographic dashboard. And for Q1 FY21, we have 1,308 employees enterprise-wide. The distribution is listed here, with community care having the most employees of 1,049. This is the male-female ratio by entity as well for your review. And here we have the tenure by entity. And you can see by just quickly reviewing this that most of our staff is within 3 to 5 years as you look at each of the entities. 3 to 5 years with each of those companies. And then the generation information as well by entity. And you can see that Generation Y, we have a pretty young workforce, and they are, leading pretty much, we're almost averaging about 50% of staff. And with that, I'm going to turn it over to Betsy, who's going to cover the turnover numbers.
Greetings to all of you. Very nice to see everyone again. And I too would like to warmly welcome our new managers who are joining us for the first time tonight. As I was introduced by Ms. Willers, I will jump right into the demographic data that I'll be discussing this evening. And this particular dashboard, the Enterprise and Central Health Voluntary Turnover Dashboard, it contains all information and charts relating to voluntary turnover, both enterprise-wide and by each organization as well. The first chart is showing the comparison of total FY 2019 voluntary turnover, as well as Q1 through Q4 of 2020, and of course, including the most recent Q1 data. Next time, fiscal year 19 will not be shown to make room, as it were, for Q2 2021 data. And the intent, of course, for this is to show trending data over several different points in time. And here you can see the somewhat upward trend, enterprise trend, excuse me, compared to the relatively stable trend for Central Health proper, plus our recent Q1 results of 0 voluntary turnover. And to be clear, the enterprise data does, of course, include Central Health data. So to bring your attention to the tables on the right side of this chart, we'd like to just mention that the enterprise rate from Q1 of 2020 relative to Q1 of 2021 regarding the enterprise voluntary turnover rate has increased 4% from this time last year. Directly below that table, of course, we can only compare our Q1 2020 rate of 10% for Central Health to the 0% rate that we're able to achieve for Q1 2021. I don't think I can say that often enough, 0%. The table below those, and so the third one down, breaks down both Community Care and Sendero into their own specific data, should you like to examine those figures further. The next chart, shown directly below those tables, displays the proportion of reasons given by employees who leave the enterprise, and I will point out just a couple of these reasons due to their respective popularity. Clearly, accepting another position is the #1 reason selected with 28% overall. Family reasons, return to school, relocation, or retirement is a close second choice, and notably, this selection is something over which we as an organization have very little, if any, control, which is important when discussing the number of employees who are actively choosing to leave our employment. While still considered voluntary, the control of us as an organization is again quite limited in affecting these numbers, as you can imagine. A particular note in the chart at the bottom regarding tenure and voluntary turnover, it is definitely worth mentioning that 40% of enterprise employees vacated within 6 months of their employment starting in Q1 21, with another 25% following, with their employment lasting only between 6 to 12 months. Let's move on to the demographics relating to Central Health proper's diversity information with regard to employee distribution and hires, and which would usually include voluntary termination information, but again, I won't say it. Let's quickly take a look at gender. Females make up 66% of our employee population, with males at 34%. New hires were rather evenly distributed via 53% for 8 female hires and 47% for 7 male hires. Moving on to the bar charts below, the first is our racial ethnic distribution. As you can see, both Latino and white populations make up the majority, with the others listed and explained as noted within your documents. To speak to the top 3, new hire racial/ethnic information, were showed equal hiring of Hispanic and white applicants at 33% each, and Black or African American applicants at 20%. Moreover, as always, we will be providing you with the population served demographics as a request by the Board of Managers that we are quite happy to fulfill. I'd like to return this dashboard discussion back to Susan Willers to complete our demographic information delineation. Thank you very much.
Thank you so much, Betsy, for your hard work.
Thank you.
Thank you. Okay, so this is the EEO 4 demographic report that I referenced earlier. And you can see this is our overall EEO4 group for Central Health. And so you'll see the admin support category right here, and the number, raw number, and the percentage of staff represented there. Officials and administrators is right here. And then the paraprofessionals category is here. The professionals category is listed here by race and ethnicity as well. And then the technician category is listed here. And so this is current staff in those respective categories. It doesn't break it by gender as requested earlier by Manager Valadez, so I think we do need to work on that. Down here, you'll see the new hires. So for quarter 1, 2021, we use the same breakdown of EEO categories and then share the breakdown in race and ethnicity as well. And so that concludes our presentation, Manager Greenberg, and we'll turn it over to you all for questions.
Thank you. I'm going to ask the board now, any questions? I'm looking on the dashboard. Manager Motwani, yes.
Yes, when we were looking at sort of the slide with the churn, it looked like well over 80% of the churn or at least in staffing was among folks who had been with the enterprise for 2 years and under. And do we have any insight on what those drivers are? I mean, that kind of churn at such a short time of employment, obviously, I think creates organizational drag. It can be quantified, however, how through whichever framework you're using. But I'm just wondering if we have any insight into those drivers. And if we don't, I don't intend to belabor it and go further. Just curious.
And I think it was actually even shorter than that, wasn't it? Really within the first 6 months, and then the 12 months.
Let me share my screen very quickly so you all can see. Yeah, it's right here.
So we see 40% within the first 6 months, correct?
That's correct.
And then we see another 25% within the next 6 to 12 months, so within the year. Do you have anything that you can attribute that to? We have 1 to 2 years at 18%, but do you have any insight into that, Susan?
I have some, yes. So for community care, we started.
Let's point out, this is the entire enterprise.
This is the entire enterprise.
It includes community care with all of their various staff.
Correct. And this is
Bureau included in here or not?
Yes, yes.
Okay, so that's what I thought. It's all enterprise-wide. Okay.
It is. But what's contributing to the 40% is really on the community care side. And what we experienced there is obviously through this pandemic, since probably August, we've experienced some high turnover due to, number one, the remote school, the closing of daycares. And so we lost a lot of staff to that. Plus, we have had, to this day, staff that have resigned due to just wanting to stay home. Some of them have resigned due to choosing to do something else instead of healthcare. But I think what's impacting this the most for this past quarter is community care hired several team members for the COVID team. And these positions were temporary positions. So we hired staff, but as a result, that staff knew that their jobs were temporary and they secured full-time employment somewhere else. And so that really is where, what's causing that turnover for this past quarter.
Thank you.
Yes.
Yes, Betsy, is that you?
Yeah, just really quickly, I just want to mention that I have never seen an organization where that is not exactly as it is. I mean, obviously the percentages would change, but the most common turnover is between 0 to 6 months and then following 6 to 12 months. So that's just, it's very, very common. That's just kind of the way of the world, unfortunately. We can do what we can to change it, but it is very typical.
that also tracks with what I have seen historically in organizations. People kind of quickly saying, "Oh, this wasn't the fit that I thought it was." Right, Betsy?
Yes, that's correct.
Manager Misaita.
Yes, thank you. My question is actually related to this slide. Well, thank you, Betsy and Susan, for the presentation. You always do a phenomenal job. Now, I'm just concerned about the 18% who have left voluntarily due to organizational fit. So if you can tell me more about it, it's like, are we not being inclusive to these individuals or not? How do we define organizational fit? And if in the future, given what you just shared with me, temporary employment and full-time employment, like part-time, if you can divide those two, maybe that would be better. At least we'll be able to see more stability of our employees. And I understand when you're working on a temporary phase, once you land a full-time opportunity, you will definitely take that position. So if you can elaborate more on the organizational fit, thank you.
Yes, so going back to the COVID team recruitment, as we hired some of these individuals, they realized that it was not really what they wanted to do. And so as a result, they turn around and turn their resignation in. And so that was really what we experienced this past quarter.
Okay, thank you.
Thank you. So we are seeing some specific, I guess I would say, repercussions with workforce in this situation with the COVID-19 pandemic, correct?
That's correct.
Right. Managers, other questions? I am looking. Manager Valadez.
Thank you, Susan. Thank you, Madam Chair. Susan, is it possible to eventually get this data broken down by entity? You know, community care as opposed to Sendero, as opposed to Central Health, so that we can see that there may not be some trend or pattern occurring at the individual agency level overall. And with respect to the numbers where you have percents provided, is it possible to do as you have done in some of the other sections of the slides where you do the percentage and then the number, so that we can get a feel for, you know, like here in this one that I'm looking at where it says voluntary turnover reasons, and you have 17 or 28% accepted another position. Well, at what level? Were those hired as administrative support staff, or were those hired at professional levels? Because if they were at professional levels and they left because they accepted a different position, you know, then I'd want to know if there's something going on. And I don't know whether or not anybody's interested in looking at that, but that would be something that would be important to see. It would go to environment, and you go to culture, you know, climate, whatever. So.
Certainly, I'll visit with Betsy to see what we can do with those numbers and how we can break them down.
Thank you.
Yes.
And I understand you telling us Central Health is disaggregating it for Central Health and Enterprise, but I would be more curious about it to the different entities, Central Health, Community Care, and Sendero. You know, just to make sure that there isn't something going on. There's not a pattern or you know, just a trend.
Manager Valadez, if I may, I just want to share that the Community Care Board does review their own turnover data on a monthly basis. Their VP of HR does that. And so I just want you to know that that is being reviewed by the Community Care Board and see.
Right, but we don't get access to that information. That Community Care Board is doing it for themselves. If that is being shared with you, or if you're sharing it with us at Central Health, then, you know, as we receive these reports, maybe on a quarterly or annual basis, we would be able to have an idea as to the state of affairs for our various enterprise per entity.
Thank you.
Thank you.
Members, anything else on this item? I am looking. I'm not seeing, neither seeing nor hearing anyone speak. Just grab my attention right now if you have anything else on this item. If not, then we will be moving on. So I'm not hearing or seeing from anyone additional on this item. We will be moving on in our agenda. And the next item is agenda item 6, which is discuss and take appropriate action on the employment contract between Central Health and the President and Chief Executive Officer of Sendero Health Plans, Inc. Susan Willers and Manager Bell will be presenting. I will turn it over to them.
Susan, did you want me to go first?
Yes, sir. Please.
Okay. And please pardon my internet connection. It's been going sort of on and off tonight. So if I freeze or something, give me a little time. First of all, welcome to our new board members. We are very happy to have you here. I'm really happy because it makes my job of getting quorums in my committees a lot easier. And so, but welcome, and hopefully at some point in time we can meet in person. Sendero's relationship to Central Health was talked about in the previous agenda item. They are an affiliate. They are governed by Sendero's board. The board has 6 members, and I am the chair of Sendero's board. There are other Central Health staff that are also on the board. This item brings to you a contract for the CEO that has expired, and the new contract must be approved by the Central Health Board, and this is in aligns with our bylaws. There was discussion during our last approval of the CEO contract with regard to the length of the contract, and there have been some changes that have been made in the contract to the length of the contract. There will be an evaluation done on the CEO each year by the Sendero board. If the evaluation doesn't meet expectations, or if for any reason the Sendero board needs to take actions, the contract can be terminated by the Sendero board. However, if the evaluation meets expectations and no actions need to be taken regarding the CEO, then the contract renews without having to come back to the Central Health Board for 3 years. So the term of the contract is for 3 years. After 3 years, the contract expires and will need Central Health Board's approval. Susan, I think that each of the members have a copy of the contract, or there was a copy in their backup. And that contract has been reviewed by the Sendero board, and we recommend its approval by the Central Health Board. Susan, anything to add?
Nothing to add, Dr. Bell.
Manager Val, yes.
I was just going to turn it over to you.
Yes, thank you. So I will entertain questions from managers, and I see Manager Valadez has a question. Manager Valadez.
Not a question, but I didn't know if Dr. Bell was making a recommendation in the form of a motion for approval, and I was going to second it. If not, I was going to make the motion that we approve the contract.
Okay.
And ask for a second, but I was assuming he was, since he recommended it, I was assuming he was making the motion in that form.
Who wishes to make the motion?
Dr. Bell?
All right, I will make the motion. I move that the board approve the employment contract of the Sendero's president and CEO as presented by staff and myself.
Second.
Okay, so there's a motion by Manager Bell. There's a second by Manager Valadez. I'm not seeing or hearing anything else, so we will proceed to a vote. All those in favor signify by saying aye. Aye.
Aye.
Opposed, same sign. Any abstaining? Thank you, managers. Thank you. We will move to the next item. The next item is agenda item number 7. Nope, it is not. Just did agenda item number 7. Nope, we did agenda item 6. So I am correct. We're on 7. Yes, I saw Sendero again. I have to make sure I'm on the correct Sendero item. So we are on 7. Receive and discuss an update regarding Sendero Health Plans, Inc., including an update on enrollment for 2021. Members, there is no presentation on this item. There were materials included in the packet for review, and Jeff Knodel, Stephanie McDonald, and Wes Durkowski are available for questions should you have any. So members, are there any questions? Okay, I'm not seeing or hearing any questions on this item. There is no motion necessary. So we will then move to agenda item number 8. Discuss and take appropriate action on project plans to advance the Eastern Travis County service expansion. Stephanie McDonald and Jeff Knodel will be presenting, and I will turn it over to them.
Thank you, Chair Greenberg. Good evening, Stephanie McDonald, Vice President, Enterprise Alignment Coordination. I welcome to our new managers, Managers Brinson and Motwani. This item may feel like you're starting a book in the middle, and I'm available, of course, after this meeting should you require any additional context for our ask. It is my extreme privilege to bring these project plans that advance clinical service expansion to 3 underserved areas in Eastern Travis County to you. Those areas include the communities of Hornsby Bend, Del Valley, and Colony Park. If you want to advance to the next slide, please. Tonight is further evidence of the team effort, knitting together many talented, dedicated staff members throughout our organization, including the healthcare delivery team, communications outreach, strategy, finance, and our small but very mighty real estate construction development team, which, I want to point out, we may say team and department, but sometimes that is a bench strength of 1. So this is really a very mission-driven and dedicated group. And I want to acknowledge and thank everybody who has contributed from across the enterprise to help shape these project plans and this work. Although tonight is probably the culmination of the planning effort, it does begin the commencement, with your approval, the commencement of the construction phase. And I think this is just another milestone to demonstrate to these communities our commitment and our extreme desire to make sure that we are closing disparities, that we're improving health outcomes, and that we are really working with communities to help them and empower them to improve their health. Hornsby Bend is a community. If you want to go to the next slide, please. I'll show you just a little bit of a demographic profile. There's a lot more data about each of these communities that exist in the project plan appendixes. It is a community that is relatively small in population size. I'll show you in geography in just a minute. It does have a very high Latinx population and a sizable African-American Black population as well. What is interesting is that even though it is small in size, in terms of overall population size, it has a relatively modest number of central health enrollees of that population. It has the highest utilization of all of our Eastern Travis County priority areas. So I think it shows you that even though this area is remote and farther away, maybe in geography, they are able to access services, maybe driving considerable distances to them. Southeast Health and Wellness Center and North Central being the two areas, the two health centers most frequented. If you'll go to the next slide for me. We did an extensive review of all of the available data. I know Manager Motwani, you're probably very familiar with the UDS data. We have our own Central Health demographic report. We have looked at the patient behaviors and the data that we have. When I say Central Health patient population, I'm really looking at the Medical Access Program members, the MAP Basic members, as well as other sliding fee scale programs supported by Central Health and our FQHC partners. Based on our review, we made a recommendation that this health center be a comprehensive primary care site and also have integrated behavioral health care embedded in the primary care services. The information below, the two medical providers, integrated oral health assessment program, mental health, Class D pharmacy, telehealth capabilities, came from both our clinical operator, community care, as well as our internal healthcare delivery operations team. This is what we are building to. This is not, and I want to be very careful with the community, this is not necessarily what will open on day one, but this is what we are building the health and wellness center space to accommodate. Next slide, please. A little bit more information about where we are. So if you are not familiar, Hornsby Bend is, you start on Martin Luther King Jr. Boulevard and you head east. You head east past 130, it turns into FM 969 along the way. And then you get into the community of Hornsby Bend just to the east of the toll 130. It is a community that is primarily residential. Austin's Colony, Hornsby Bend, Austin's Colony was is a subdivision in the area. There are not a lot of services in this area. And this community is really looking to this site to improve community health. And I think for this community, it is maybe different and will look different than maybe our other two projects tonight. The property purchased by Central Health is just below Daly Middle School. Daly Middle School is the building campus that you see in the kind of silver to the top. We abut a residential neighborhood, and this property belongs to the Daly family, and Mike Giesling can tell you a lot more about that family. I think they really see this as being a way to give back to this community, and when they sold that property to us. We are looking for to build approximately 7,500 square foot clinic, and that would be the first phase. In the future, if there is need for expansion, we do have space available on this property. Next space. I'm sorry, next slide. And then one more. The project site itself, you can tell, even though this area seems very rural, I think you all know and have heard there are potential for a Tesla manufacturing facility nearby. It is a residential area, and the Del Valle ISD serves this community, and they have a number of schools. So there are a lot of potential families with children that probably need access to healthcare closer to their homes and the schools. One more, next slide, please. Just another image from about the site itself. Next slide, please. We have been working, and we are really excited to work with some really dedicated and experienced architects and designers. And if you get to the next slide, this BSA Life Structures are the professionals that have been helping us think through the concept and how to the site plan for the Health and Wellness Center in Hornsby Bend. To the left on Sandifer Street, you'll see the parking towards the front of the property, and then the health center proposed. This really does allow us to use that 10-acre site in the future for additional clinical or community wellness space if we need it. It does accommodate a number of wellness features. And I think this really speaks to kind of the need in the community to have an improved community health. There's, I think, we talk frequently about the healthcare that occurs outside of the exam room, and I think this space is really looking to help support health and wellness outside of the clinic walls. Next slide, please. This is just a concept, and I want to tell everybody these are just renderings that BSA has put together to help us kind of just visualize what it might look like. The back of the property is wooded, and we would really like to take advantage of that, and maybe use that space for walking trails, wellness, fitness paths, and make sure that it does support the neighborhood just to its rear. Next slide, please. This is again conceptual. We really want to work with the community, make sure that we're putting the amenities and the services that speak to this community. One of the things that I think we've learned in the pandemic is that isolation is a health issue. Loneliness has been a real problem for many during this time of pandemic. And this community really mentioned that they have a senior population. That senior population, of course, right now is isolated, has nowhere to go. They also need places for distribution of food. So we have really allowed for the flow of traffic. We know that we are not out of the woods, that we might need to plan for future pandemic. So some of the way that the campus has been kind of conceptualized in this rendering supports our ability to deliver services either by car or to manage kind of traffic flow better. Like I said, we really do, and I'll show you in a few slides, want to work with the community and making sure that we are meeting their needs and working with community partners to provide additional services to this area. Next slide. Again, just a little bit more about what we see in terms of the building program or what services that could be accommodated in the building. I think the community room, and we have this idea of community workstations. We know there's a digital divide that especially impacts this area, making sure that we have places where people can access, especially in these times, many of the services that are vital, registering for SNAP and TANF assistance, et cetera, is all done virtually. So we need to make sure we have places that can safely accommodate access to those services for people who don't necessarily have either broadband access or computers at their home. Next. This is just a diagram for kind of conceptual purposes only. We are really going to need to work with our clinical operator to make sure we're meeting the needs of the clinical operation. But what this shows is kind of a segregation of the community space, potentially offices that will have other partners that can provide services to this community. But we can close off that clinic space and use that community space at any time of the day. And that's kind of what we are building towards, and our operations plan incorporates having dedicated people that may not be clinic staff that will be able to serve as stewards of the site. Next slide, please. We are really working aggressively to get to a groundbreaking this fiscal year. This is my goal, and it is a stretch and ambitious goal, but our designers have humored us, and they think that if we can get busy, we can be well on our way to construction kickoff this fall. Part of the timeline is a little bit more accelerated for Hornsby Bend. It is in the city's ETJ, so we have less regulatory hurdles and permitting time necessary for that. Next slide. I did mention we've had a really extensive and robust effort to engage the community in Hornsby Bend. Like I said, this is a community that has been underserved. I think I've heard some really amazing stories about how residents have had to fight for water, they've had to fight for roads, they've had to fight for a lot of services that, and quite frankly, I think are ignored, and because of their kind of remoteness from the core of the county. I think are often overlooked. We have a number of tactics and have already scheduled some key dates. This is really just based on the construction schedule and when we think we'll have information for them or would want their input to help inform the design of the site. Next slide. You know, we want to be good stewards of the taxpayer dollars, and but we also want to be, we know we get one chance to do this right for the community. So we have an estimated a little over $5 million, and this is really around the capital investment required for the site. And we'll have some more information later about some projections in terms of startup and operating cost. This is the community of Hornsby Bend. If you were going to move further south, next slide, please. We're going to go to Del Valley. Here's the demographic profile for Del Valley. Similar, but larger. And what is interesting is we've had more enrollees in the Central Health Covered programs. But we have similar utilization. They're primarily going to the Southeast Health and Wellness Center in South Austin. It's part of some interim steps before we get to a dedicated health and wellness center. We have been sharing the Travis County Employee Wellness Clinic. Even though that is located to the west of 130, we have seen considerable uptick in utilization at the site. Our clinical operator community care has seen increased utilization at the site. We know that there's also a lot of growth in families in this area, and I think we're seeing potentially a different mix than maybe what is in Hornsby Bend. Next slide, please. We are really seeing this as it being a larger site. It's going to be more probably dedicated to health services, clinical services, including dental services. We are evaluating pediatrics, dedicated pediatrics, obstetrics at this site. Also, given the lack of other commercial businesses, we see a lot of opportunity in having a retail pharmacy with a drive-through that would serve anybody in the community. They would not necessarily have to be a patient of one of our clinical operators to get their prescriptions filled at the site. We're not ready to sell milk yet, but we would maybe, evaluating opportunities, clinical operator to be more of a retail destination. Next slide, please. So like I said, we are working with O'Connell Robertson, and I want to point out that many of the architects on both projects, both BSA and O'Connell Robertson, have worked with us on previous projects, including the Southeast Health and Wellness Center and North Central. You will see some pictures sometimes in some of these presentations, and they're coming straight from other health centers that they helped design. That are our health centers as well. This Del Valley, again, we are looking east of 130. This is adjacent to Popham Elementary School in the Del Valley ISD area. It is in the city's limited purpose ETJ. It's a smaller piece of property that we were able to acquire than in Hornsby Bend, but I think it's well situated. It is at the intersection, there is a small convenience store, and there's a relatively new fire station across the street. We're looking about 14,000 square feet right now of the Health and Wellness Center space. Next slide, please. One more. I think that just shows you a little bit more context about where we are, kind of just to the northwest of Circuit of the Americas, southeast of the airport. One more slide, please. Again, the building to the left is the Popham Elementary School, and the track is in between our project site. One more slide. Next slide, please. Working, we've had to kind of design this site. It's, like I said, a smaller piece of property. Originally, I think there was some idea when we purchased it that maybe we would lease space out to other retail uses. in evaluating our clinic program and the potential need in the community, we increased the square feet that we are allocating to the clinic space at this point. And I think, the recommendation will probably be to go ahead and take that remaining almost 4,000 square feet and build it out as a core and shell, and really talk to our clinical operator about future expansion opportunities. And we'll come back to you, of course, should we make any recommendations in that area. You can see the retail pharmacy plan to the left. And again, this is a site plan. This will have to get reviewed and approved. There are a number of features on here that we will have to include just to meet water quality standards and make sure we're meeting all of the regulatory requirements. Given that this is in the limited purpose ETJ, we are having to take all of that into account in the design. Next slide, please. We are working, this was just I'm sorry, that slide was a preliminary concept. Here's a revised concept, looking at ways that we can incorporate more community space after feedback we heard from the community. This also allows us to maybe to do more of that remote or car service if we're, if that's required given pandemic situations or other public health emergencies. We did have this site situated where there are two ingress-egress points as well, just to accommodate traffic flow. Next slide, please. Again, a conceptual rendering of what it could look like. Next slide. This slide is in here not because we think, we need to have electric vehicle charging spaces and solar panels, but we are working with the city and they have asked to work with us around creating resiliency hubs. This is something that has come out of their work post Hurricane Katrina, actually, and some of the global climate change concerns, creating places that serve as community centers, especially when there is no power, when maybe there are water shortages. I think we have maybe forgotten with all the pandemic concerns about, it wasn't that long ago that we had a boil water notice in the city of Austin for a while, and we all had to drink bottled water for a period of time. Well, there are communities that are either not on the city water supply, or if they were in this situation, don't necessarily have access to purchase water regularly. So these are all features that we are looking at to work with the city as a resiliency hub. Hopefully, a lot of this can be grant funded as well. So, we're taking that into consideration. Next slide, please. This shows you kind of the square feet that we are seeing. That does include that roughly 4,000 square feet that isn't in the current service plan. Next slide, please. Again, this is a design concept. We will work very closely with our clinical operator to see if this makes sense. We are looking for common maybe areas, but we do want to maybe also have the potential for dedicated entrance and maybe the incorporation even of, for example, carousel pediatrics at the site. And like I said, this is really going to be work that we have in the future with the clinical operator. We've heard very clearly from them as well as the community that they would like to have pharmacy access, and that pharmacy access will be, accessible both from the outside, from potentially the drive-through, as well as inside the clinic in the current plan. Next slide. Again, this looks very similar to the Hornsby Bend design schedule, but we would really like to get to a groundbreaking this fiscal year. So September 30th, I might make up a September 31st this year. Get your hard hats and shovels out because we really do want to meet that goal. Next slide, please. Again, working very closely, there's been a lot of work over the last couple of years invested in creating these advisory groups, working with the community and community leaders and trying to identify people who will, help us in the design and in the concepts around this health and wellness center. So more dates that we will meet with the community. This is a proposed schedule based again on the construction timeline. Next slide, please. This project does have significant costs. It's really because we are seeing more clinical services in a larger site. Next. Colony Park. Many of you know the Colony Park community. It is the closest into the center core of the city. We have been working with the city of Austin and the property they own, the 208 acres in the master plan community off of Loyola Lane. We have a demographic profile here of this community. It has, interestingly enough, the largest number of people enrolled in central health programs and coverage, but it has lower utilization. And so we want to kind of, we've been teasing that information, delving into that data a little bit more. Next slide, please. We do know that with that enrolled population, they should be accessing care, and we would hope that they would know if and we hope that if the care is more convenient and accessible to their homes, that they will utilize the services. We are looking at comprehensive primary care, integrated behavioral health, dental services, and the addition of mammography. We know that this community is not accessing mammography at the rate that we would like for them to, and feel that this would be a great place to locate a mammography unit. Next slide, please. This slide is, details what it would take, we believe, to build what we just showed you in that previous slide. I think you know that we've been working with the city of Austin. We do believe we've come to terms on the land value itself, but it is contingent upon the city being able to extend utilities and infrastructure to the site on their master plan campus that fronts Loyola Lane. And that is still in negotiation. We hope that they will be able to negotiate with Catellus by the end of February. And while this is also going on, there has been a lot of community desire to see additional services located at the site. We've been working with Austin Public Library, Austin Public Health. There may be other city departments that see the need to have a site here that serves the community. And so we believe that we will have an interlocal agreement that will speak to the land acquisition, the infrastructure, and possibly even how we can have a financial arrangement where we could help the city in advancing these services on the site. So with that, we will have to come back to you, we hope in February or March, with this interlocal agreement, a lot more information about what the site could accommodate, what we think of as maybe the capital investment, how we are going to plan for any future growth on the site for the clinical services, and what potentially the reimbursement structure would look like with the city to support these additional city services on the site. Next slide. I'm going to turn it over because really what this is a financial ask of you, the board, tonight. I'm an English major, so I'm going to turn it over to somebody who actually knows something about money, as a CPA. So Jeff, if you want to walk through the slide with the board.
Thank you, Stephanie.
And let me say, Stephanie, thank you. I think you may be able to take a breath now. That was an amazing amount of information, and the presentation was robust and excellent. And thank you for all of your hard work and the many, although the staff is, I know, very slim, the others who have worked so hard. And Jeff, I know you've been hard at the number crunching, so please continue.
Yeah, thank you. My job on this is just one slide, and it's relatively easy. I think you've seen a lot of the information. There are two pieces of information that you're seeing on this slide. The upper portion is the capital budget, more from a timing perspective of how the dollars would be spent. And just as a reminder, when we go through our annual budget, we typically budget year to year, but for a capital budget, you want to try to budget by project. And so, for example, you don't want to budget just one fiscal year and then not have the funding commitment to finish the project. And so we've laid out a timeline over multiple years for a commitment, a budget commitment for each of these 3 discrete projects. So Stephanie has talked a lot about the components of it. Just looking at the timing of it, I think they correlate with the timelines that she laid out. And we're requesting action related to these budgets, knowing that at this point we've spent a lot of time working through the numbers. There may be some amounts that may be subject to change. I think Colony Park that Stephanie was mentioning certainly has that possibility. And if it does change, we would come back to the board for an amendment to the project budget. The lower portion of the slide shows the operating impact, the operating cost for year 1 and year 2 of each facility. And I will caveat these estimates. These are only estimates. At some point, we are picking up assumptions from our clinic. We operate in the area and simply picking those payer mixes up and increasing the volume for that. And we know that's not correct. But nonetheless, we really need community care to help us with these estimates. They have committed to doing that over the next couple of months. And we will come back with more detailed information and better constructed information related to the actual payer mix. So the way we put this portion of it together is in looking at the first 12 months of operation, once the clinic is, the construction's completed and it's open for service, is a 12-month ramping period. So in other words, on day 1, you're not starting with full staff, a full patient load. You generally ramp up over time, and we're ramping up over that first 12-month period. And you see a low and a high estimate for that period that simply looks at the potential MAP and MAP basic spend for each clinic over that ramp up period. So granted, the timing won't be the same for each clinic, but it's an estimate of the first 12-month period. And then year 2 is actually a range for full operations of each clinic. And so you see a high and a low estimate for each of the clinics. And I think the one of the big challenges related to the clinics, I think Hornsby Bend has a lot of information that will be fairly accurate to community care's perspective on it. We know that the Del Valle payer mix will change just because the location of the clinic being adjacent to an elementary school, we'll probably see a lot different payer mix at that facility. And so we will need to adjust our estimates and payer mix over time. And then of course, Colony Park is not quite as far along. But the purpose of the slide is really at this point, and again, this is an early point, is to provide the board an estimate of the operating commitment that would be required over the first 2 years, and certainly just taking year 2 and taking that and looking at that forward as full operations, just extrapolating what those amounts would be. It gives the board an idea of some of the operating budget commitment that we would have to make as we operate the clinics at each of these sites. So I'm going to turn it back over to Stephanie to wrap up the presentation.
Thanks, Jeff. Next slide, please. Last slide. So we would like for the board to take action tonight and approve these project plans so we can commence the work. And with that, I'm happy to answer any questions. I'd also like to acknowledge a number of our team who have been working on these project plans over the last 6 months or so, as well as a number of our architects from both projects are also on this call. So thank you for being here tonight with us.
Thank you, and thank you to everyone who is on the call and those who are not on the call who have worked tirelessly. I am so happy, and I know the other board members are, and our new board members can probably see the work that has been going into this for months to see these plans being laid out, and the calendars. I know maybe a little ambitious, Stephanie, but I'm glass half full right now to commence. I also thank you for the financial information. You know how important I think it is, and I know that these are very much ballpark estimates on the operating costs, because we have to see what our clinical partners actually will be providing. But we need to understand. Getting feedback. Somebody may need to, close off. But we need to understand that these are not just capital costs from our capital budget and construction, but ongoing operating costs. And I'm sure as we move along, as you said, Jeff, we will get more refined estimates of the operating costs. And also, I'm sure as we move along, Stephanie, we will get more refined cash flow estimates on the capital projects according to the phases of the projects. So thank you very much. Members? Manager Musaita.
Thank you, Chair. Appreciate it. And I concur with what you said. Stephanie, thank you for a thorough presentation and for all your efforts. And Jeff, everyone, I'm really pleased and delighted to see this project moving forward. It's been years in the making. And if we learned one thing from this COVID-19 pandemic, it is the importance of access to equitable care, and how our communities of color, especially those who are living in poor neighborhoods, have been disproportionately impacted from this awful pandemic. And I hope we can break ground. I'm very ambitious, and there's nothing impossible in this world to move this project forward. But I also ask that we constantly include our stakeholders, be transparent with our timeline, because we don't want to disappoint anyone as well. We know we may foresee any setbacks in the future, but I hope we are able to really expand our clinical care services there. And it is a much needed and a service that we need to provide for our community there. Thank you so much, and I appreciate it, and I hope we'll break ground and we'll all be there soon. And thank you.
Thank you. Managers? Any Manager Motwani, and then Manager Valadez.
Thank you, Chair Greenberg. And thank you, Ms. McDonald, for an excellent presentation.
We're having trouble hearing you. You may need to get closer to your mic source.
Can do.
Yes, much better.
Brilliant. This may not be necessarily material to the entire conversation, but given my need for context here, I'm wondering how the FPL numbers were calculated, or were they the 100% and 200% FPL numbers? Are they from distinct sources? I noticed households versus families, and different denominators.
Right. So we're talking about the federal poverty level, Stephanie, and the demographic data.
Right. They were. So we have multiple data sources, and that is why they are not necessarily households or families in each bucket, for example, or for each line. I will have to get back with you about, and this is all in the project plans as well, and it's detailed how we got to the source, what the sources were that wrapped up to those numbers. But I will certainly be able to go back with you. We have both our data analytics team that produces this demographic report. We also looked at the UDS data. So depending on which source that we used, it's going to have a different number.
Yeah, and so yeah, I'm glad that I guess y'all are able to trace that. The reason I'm even looking into this is just obviously for me to sort of as quickly in a rushed manner calculate ROI in as quick and dirty of a way as possible, knowing that the best minds in the city have already been working on this, right? So I assume that we have different denominators when we're calculating the total number of families versus their income to see what the level is a little bit, it would make me feel better to see it standardized, I guess. It's just more confidence in the data source. And then on that note, you had mentioned lower utilization in Colony Park, and y'all are delving deeper into that data a bit. Could you tell me a little bit about what you're seeing? And then with respect to that, I guess within the context of specifically where that, even with the utilization that we are having, do we know what the distribution of that utilization is per site? Or
we do for, so that's interesting. So if you go into those project plans, we do like the top 5 clinic locations or sites, because they're not all clinics, right? So it gets a little bit tricky and a little bit murkier because some of this data is, for example, Delseaton. So that is one of, so, this is not necessarily, and I think, I think it really is a more complex picture around the utilization. Some of it may be around, well, there isn't culturally affirming or appropriate care in my community. Some of it may be, well, I'm not going to get primary care ever. I'm only going to go when I absolutely have to. And so I'm only showing up and presenting at Delseaton, right? So I think we are doing a number of, and really looking at kind of where and why, and asking patients is a little bit more challenging, takes more time. I think very well how difficult it is sometimes to get and tease out that information either qualitatively or quantitatively. So I don't think that is something that we've spent a lot of time on, and I'm happy to go back and circle back on some of our efforts and present that information to you. I think what we were charged with was, and I think you'll maybe hear from some others, really advancing primary care in this community. There is also the added nuance of, if we look at community care data versus our larger central health covered population, as does include your choice of primary care FQHC provider, but also we have had the addition of Carousel Pediatrics with community care family and Austin OB. And so those 2 sites in the Springdale shopping center have done a lot of, have covered a lot of the families in the area. So we're just, it's a very nuanced picture depending on what question you're asking.
That utilization presumably is that just for a 1-year period, or is that over a 3-year period? And I'm wondering if it may be just demonstrating an unintended consequence of the nightmare that is 183.
Absolutely, but I think what we are seeing is that there's more resources, that there's also more coverage rates. So for children, we're seeing a lot more, those are very highly utilized sites. But we're not sure where the adults are always going, and so those numbers are limited to adults, just so on our side there.
Thank you.
I'm happy to get more information, and I will certainly follow up with you about that question specifically.
Thank you, Manager Valadez. I believe you had a question. You're on mute, Manager Valadez.
Could you put up that last financial screen, please?
last slide that Jeff Canodal had, yes. With the capital budget and then the operations below it.
That one right there.
Yep.
Okay, so, you know, I know Del Valley, I know Hornsby Bend, and I know Colony Park. And I'm looking at the areas, and then I'm thinking about what we would be putting there in those areas. Colony Park is City of Austin. They're on a bus line. They have Lone Star Circle of Care and a big new facility just north of them on 290. Maynard is going to have another clinic out there, and that's all in that area, that northeast quadrant. Across the street, from 183, you've got the Springdale stuff and access to Mueller. Real quick, out in Del Valley and Hornsby Bend, you have nothing. There is no incorporated area. There's no city. There's no nothing. There's nothing. There's no buses. There's no pharmacies. There's no departments. There's nothing. And yet at Colony Park, you're going to be asking for 1.5 in 21, 8.1 in 22, 8.1 in 23. And you look at the other two areas, Hornsby Bend and Del Valley, and if I combine the families, because they can go up and down the frontage road, the toll road, to get to each other pretty quickly. And that's a combined 17,551 households just in those two areas, Hornsby Bend and Del Valley, as opposed to Colony Park, which only is going to have about 8,000, almost 9,000, 8,896 households in Colony Park. So I'm sitting here trying to understand why we're spending so much money in Colony Park, and and give them mammography, give them all this stuff, and out in this area, out in the boondocks, where they're outside of 183, they're so far removed from anywhere, they can't get anywhere unless they have a car or paying somebody to take them. I'm trying to understand the monetary assignment to the centers that are going to be providing so up here, what maybe it sounds like, and I don't know, because I don't know what's actually going in there. There's so many people that need so much, and it doesn't appear as if there's an equitable distribution of funds for that. I'm trying to have somebody explain that to me. And is that based using community care, demographic information on utilization, what is being used by their clients who are accessing services in other areas, because they don't have it there at Hornsby Bend and Del Valley. And Colony Park, which is access on a bus line and in the city of Austin, you know, their utilization is so much less, but that's fine. But I know out there they have lots of families, lots of children, lots of mothers who need access to female services. And I'm just trying to understand how this was developed.
Thank you.
If somebody can help me. Thank you, Sherry.
Thank you.
Madam Chair, if I may.
Yes, Mr. Giesland.
So I understand your question, Manager Valdez, and within each one of these, both the capital portion at the top of the slide that's on the screen, as well as the operating portion that's on the lower portion of the slide. Mm-hmm. Each of these are very unique sets of circumstances. The real estate transactions, for example, the cost of the land, the cost of build on something that is level versus sloped, on something that has utilities nearby versus that which does not. And, you know, when you add all that up and then you look at the data and the programs and working with clinical partners to come up with, again, what is a preliminary estimate in service arrangement, it's more complex than what my words here are giving due credence to. So what I would really encourage, and this is going to be an iterative process. I mean, we're coming back here and we're asking for permission to proceed with what we presented here today in these projections, so that the board and the public is fully informed and there's transparency in terms of how we're moving forward. But I would really encourage the board to recognize that each one of these has its own unique set of circumstances. And there are other areas with extremely high need that are not on this list. And remember, these focus areas came about in 2018. Which you'll remember those conversations, and that's why they're on this list here today. To suggest that there has to be a leveling of dollars across these sites is not going to recognize or work for the unique set of circumstances that exist in each one of these. And as a board member, certainly it's your prerogative to ask those questions, and for
that
us
wasn't my response. That wasn't my question. Excuse me. I just was trying to understand whether or not we were using the data that community care has for utilization and what the mix is of the families within those areas.
There were extensive data sets used, including those from community care.
Thank you. But no, I was not. Don't infer that I was trying to equalize it out. No, I was just trying to see whether there was.
Thanks for clarifying that. Appreciate it.
Okay, please.
Thank you. Stephanie, did you wish to
I just want to add that we want to make sure that you recognize that the numbers on the bottom half of the slide include the reimbursement for the services. So certain services also reimburse it. We have adult dental, we are the primary payer. You have a lot of dental need because we are the primary payer of adult dental services for the low-income uninsured adults in Travis County, right? So, those changes really do add additional dollars to this bottom portion as well. And I just wanted to point that out.
Maybe we can have a separate conversation, Stephanie, about this.
Manager Brinson has a question. Manager Brinson.
Wanted to know, are all three of these the projection for growth in these various communities? Are they projected to grow fairly equally? Are you expecting Colony Park to grow, by leaps and bounds, and then the Central Austin area to not grow at all? What are you looking at in growth potential?
Thank you. So that's an excellent question. And I do want to say that we have an extensive demographic report. And I don't know if you've had an opportunity to see this. I'm sure you will, parallel with the orientation, the information it's provided. It's actually on the website that was completed by our staff a couple of months ago. And so you may want to look to that. And it is, as I said, quite extensive demographic report of all of Travis County, comparing growth, comparing various economic indicators and others. But did want to make sure that staff points you to that. And with that, I'll turn it over to staff to answer the question.
We are absolutely looking at a number of factors, and we don't have crystal balls. And I always joke, and I've joked with the team, if we were HEB, we could really, we would know exactly, right? They have fleets of people dedicated to this kind of strategy and real estate development and the kind of utilization, the consumer insight, right? We don't have as much of that. So we are being, I think we're trying to be good stewards, but we're also trying to honor some longstanding commitments that we've had in these communities that we would provide, access in there within their own communities to care. And so this is the balance that we are in. We don't necessarily know. I think, part of how we approach this and the planning really did take into the unique geography and what we know are the trends in some of these areas. Colony Park is, part of a community that, right now has a lot of families that are struggling and really working. There's a lot, if you talk to, for example, the school principals, just qualitative data about how many families that are living, in situations where there's multiple families living in a housing unit. So there's a lot, there's a growing number of multifamily units. There's a large community that is in modular homes. So, where that community is going is a little bit harder to predict. And I'll be quite frank about that. It's been a number of years. I think the 208-acre master development area has been in the planning for over a decade. So, there's a lot of immediate need, and we want to be able to be responsive to that immediate need, but also, be good stewards. So we're looking at a number of factors. That's a long-winded way of me saying that.
Mr. Giesland, did you want to contribute to that?
No, I just want to echo the demographic report that was mentioned. And
that I mentioned, yeah.
We'll get that to the new members, but also wouldn't hurt for the existing members to have a refresh on certain pages, because we do track.
That's right.
A 5-year growth trend on poverty levels as well as population levels, as best we can with the projection abilities that we have.
Yes, exactly. That's why I was pointing everyone to that. But as Stephanie has stated, there were commitments made by the board. There are longstanding inequities, and although we don't have crystal ball, we know that there are certainly companies that have located and are looking to expand, and probably more coming to these areas. Manager Musaitov?
I'm ready to entertain a motion if you're ready.
Managers, anything else? All right. Manager Valdez, yes.
Stephanie, I just wanted to make sure that we understand if we could have another conversation about this, and so I can explain better or more fully what my concerns were. And also for the board members that may not have seen, the census information is going to come out in April, end of April, hopefully.
Well,
we'll have
some
that.
of it won't be out till July, but anyway, that's a whole nother
That's what they say.
can of worms.
Thank you.
Okay. I know that Stephanie said that she's happy to meet with any of the board members, our new members.
And I gotta point out, I'm not the brains of this operation, so there may need to be other people who actually are the brains, the Saritas, the JPs of the world.
Yes. Okay. Yes. Yes. Clearly, on the demographics, we need to give a big shout out once again to JP and Sarita for that outstanding demographic report. All right, Manager Musaitov, I want to recognize you for a motion.
Thank you. I move that the board approve to commence work to advance clinical expansion on the Hornsby Bend, Del Valley, and Colony Park projects in accordance with the projected capital budgets detailed in the project plans in the staff presentation.
We have a motion. Is there a second? Manager Valadez?
Yes, I'll second that, but I understand. I just want to make sure this is a work in progress, correct?
Absolutely. We made that quite clear. Yes.
Go for it.
Yes.
Del Valley has been waiting a long time.
Yes. Yes, ma'am. So we have a motion by Manager Musaitov, a second by Manager Valadez. All in favor? Aye.
Aye.
Opposed? Same sign. Any abstaining? Thank you. The motion passes.
Thank you very much, members, and thank you, staff, for putting all this together.
Everyone else, thank you so much. Okay, so we will now move to the next items on our agenda. We have agenda item 9, discuss and take appropriate action on Central Health owned or occupied real property and potential property for acquisition, lease, or development in Travis County, including next steps in the redevelopment of the Central Health downtown campus, administrative offices of Central Health Enterprise Partners, and new developments in Eastern Travis County. And agenda item number 10, receive a briefing regarding Central Health Enterprise information security issues. Members, I announce that the board is convening in closed session to discuss agenda item number 9 under Texas Government Code section 551.072, deliberation regarding real property, and item 10 under Texas Government Code section 551.0891, deliberation regarding security devices or audits. So members, what we will need to do is leave this completely, and you should have received a link to go to for our closed session. Do we need a 5-minute, 10-minute break? Yes, Mike Giesland.
Madam Chair, and if I missed it, we also need you to read agenda item number 10 before we go into closed.
I did read it.
Oh, I'm sorry.
She did. Absolutely.
Yeah.
My apologies.
Okay, I read it. So how much of a break do we need, managers? Put up a hand. 5 minutes? Is that going to work? Okay. So we will take a 5-minute break. completely get off this and go to the link for the closed session. We will see you in 5 minutes. Hello, hello. Okay, members, are we all assembled? Let's see. I see Manager Musaitev, Zuniga, Valadez, Motwani, Bell. I do not see Manager Brinson.
Yes,
There she is. That's why I'm calling out. It's hard to follow all the little squares popping up here, there, and everywhere, moving around. Okay, it looks like we're all assembled, correct? David, are we ready to rock and roll?
We are.
Okay, so we have completed our closed session. It is Wednesday, January 27th at 9:53. Agenda item number 9, do we have a motion? Members? Manager Musaitev? You're on mute.
Sorry. Item 9, correct?
Correct. Item 9, agenda item number 9. There's a motion.
I move that the board approve amending the fiscal year 2021 capital budget by increasing the Red River realignment project budget from $5 million to $8,463,669.
We have a motion by Manager Musaitev. Do we have a second? We have a second by Manager Bell. All in favor? Aye.
Aye.
Opposed? Same sign. Any abstaining? One abstaining. Manager Motwani. Okay. Thank you, managers. Motion passes. The other item we had was agenda item number 10, receive a briefing regarding Central Health Enterprise information security issues. We have no motion necessary on that. So we will now move to agenda item number 11, receive and discuss the 1115 Medicaid waiver, delivery system reform, incentive payment, open paren, district closed paren projects. The Community Care Collaborative and other healthcare delivery partners, programs, projects, and arrangements, including agreements with Ascension, Texas. Monica Crowley will be presenting. Monica, you have the floor.
Thank you, Chair Greenberg, and I'm Monica Crowley. I'm the Chief Strategy and Planning Officer and Senior Counsel, and this is a 2-minute, 130,000 foot update on something that we could and probably will talk about for days over the next coming months. So this is about the fast track renewal of Texas's 1115 Medicaid waiver that was announced on January 15th of 2021. At the highest level, as with many of these types of supplemental Medicaid program decisions, there are two sides to it for Central Health. I'm going to start and end on positive and sandwich in the less positive in the middle. So the first part of it, the good news is that overall for the state of Texas, funding levels for this program is anticipated to remain undiminished, and CMS and Texas's Health and Human Service Commission's overall intent was to help providers sustain the achievements of the DSRIP Delivery System Reform Incentive Payment Project, although DSRIP is still going away at the end of this year. Uncompensated care remains stable, and potentially in the next couple of years, funding for the hospital uncompensated care pool potentially could increase a little bit. So that is very good news. And the hospital enhanced Medicaid payment program that formerly went by the acronym URIP is now a program that is called CHIRP. And that is proposed, I know, I love Europe to CHIRP. CHIRP is proposed at an even higher funding level than the Europe program was, and more hospitals will be able to potentially qualify for and receive over $5 billion for the state of Texas as proposed in supplemental enhanced Medicaid services. One final bit of good news around uncompensated care is that there is a new UC pool that has been established for public health authorities like Austin Public Health, and another Medicaid enhanced payment group, payment pool, direct payment program for local mental health authorities like Integral Care that should make up for those organizations the losses that they would have seen if the DSRIP funding just went away. So there's a lot of good in this as announced. The less good news for Central Health is that for Central Health right now, as drafted, neither Central Health nor the Community Care Collaborative nor the federally qualified health centers that we work with can participate in these programs directly as proposed. And so we are still facing the DSRIP gap that we were facing before this fast track was announced. So the good news on this is that the good news I'm going to end on at a very high level is that HHSC is aware that fast tracking this has created some gaps. They are actively seeking input and feedback on these gaps. Central Health has already submitted comments on the requirements for the rules for the TIPS program, which is a provider practice program that is a direct payment program that potentially, if they accepted some of our notes, that Central Health would be able to participate in. We'll continue to submit comments about measures for these programs. We'll continue to have conversations with HHSC and Perla Cavazos, Celso Baez, Katie Coburn, Jeff Knodel, and I will be working diligently on this with our partners. We also have some outside counsel that's advising us on this. And I know that Mike's been involved with the Teaching Hospitals of Texas group, which is also actively gathering feedback and input and reaching out to legislative delegations and really, trying to join together to come up with a way that, organizations like the federally qualified health centers and Central Health, that we don't lose the advances that we made through the DSRIP program. And so there will be more to come over the coming months.
Thank you, Monica. This has been, for years, constantly shifting ground, I guess is the way that I would put it. And what I hear you say is that this is a journey. And clearly, you and others are on this, monitoring it, being proactive, and will be coming back to us as we continue on this journey, correct?
Yes, ma'am.
All right. Any questions, managers? Manager Valadez.
I'm not going to ask you openly.
10 o'clock, Valadez.
Yes.
Hello?
Yes. Can we have a brief question?
Yes, I thought I heard some chirping in the background, but I couldn't tell what it was. Monica, I will talk to you offline. I do have some questions regarding where we are with DSRIP, and I just wanted to make sure that I communicated that to you during the meeting.
Thank you. Okay, managers, anything else? Okay, we will be hearing more. So if there's nothing else on this item, we will move to item number 12, which is confirm the next regular board meeting date, time, and location. Managers, our next Central Health Board of Managers meeting is scheduled for Wednesday, February 24th, 2021 at 5:30 p.m. at the Central Health Administrative Offices, 1111 East Cesar Chavez Street, Austin, Texas, 78702, and or remotely by video conference, depending on the status of the governor's disaster declaration and stay-at-home orders. At this time, I'm ready to accept a motion for adjournment.
I move adjournment.
Second.
Manager Bell moved adjournment. There was a second by Manager Musaitif. All in favor, say aye. Aye. Opposed, same no motion. Any abstaining? Members, thank you very much for the
Thank you, members.
participation. And our new
you.
members, we are adjourned.
Thank you, bye.
Thank you.
Thank you.
Bye-bye.
Bye.